Thank you. Respected teachers, seniors, colleagues, dear friends, it gives me great pleasure to welcome you all on the occasion of this webinar. This is the 5th webinar conducted by our chapter, and this one will focus on the role of echo in structural heart intervention and in the assessment of prosthetic valve function and dysfunction. As you heard, together, myself and Professor Shiva Prasad, the scientific committee chairperson, have about 5 minutes for our opening remarks.
Okay.
I'll be very brief. Let me at the outset welcome the invited faculty. Professor Raj Janardhan,
Delegate link chat ചെയ്യാം.
from Arizona, USA. I intentionally avoided the city name. It's spelled Tucson. And for a long period of time, as a college student, I used to pronounce this as Tucson. But when my child grew up, she corrected me and said that it is pronounced as Tucson. But anybody who grows up in those years reading the Wild West stories of Oliver Strange and Louis L'Amour is certainly familiar with the city Tucson. Thank you, Raj, for agreeing to enlighten us on the echo assessment prior to planning a mitra clip. Next, it's my pleasure to welcome Professor Bijulal, a Sri Chitra Tirunal Institute alumnus, to talk to us on the newer concepts in echo evaluation post-TAVI. Welcome, Dr. Bijulal. And finally, I welcome our very own Professor Matthew Ike, who has agreed to talk on the various aspects of prosthetic valve function and dysfunction. Thank you, Matthew. Let me now thank Dr. Joe Joseph, who took the initiative in organizing the webinar and garnering the resources for the same, all in the space of perhaps less than a month. Great job, dear Joe. Finally, let me congratulate Professor Shiva Prasad also. He had the quite unenviable task of charting out the scientific program and wading through the countless abstract submissions. I believe it was more than 2 dozen to shortlist the case presentations. Needless to say, he has done a wonderful job. I'll conclude by welcoming all the senior faculty. Professor Vijayan sir is already here. Dr. Rajan Joseph Manyuran sir, the brains behind this program. Our previous president, Prabhanini Gupta, I do not know whether she is already logged in or not. All our executive committee members, I saw James Thomas briefly, and all the delegates. Hope you will all enjoy and actively participate in the sessions and proceedings. And after the remarks by the scientific committee chairman, as Dumbledore, the principal of Hogwarts School of Magic and Wizardry, would say, let the show begin. Over to Professor Shiva Prasad.
Thank you, Suresh sir. And sir has done said everything about this workshop, which was arranged in a very short span of time. And I really congratulate the organizing secretary, Joe Joseph, to organize this in this crystallized form. And I am not taking too much of time. It's already 4:33. Let us go to the scientific sessions. We have a good scientific session, I guess, before us. That is of most relevant topic which we deal with today, that structural heart interventions and prosthetic valves. Let us have the first session going in. And we will I'll just hand over to Joe to start. Joe? Joe, mute on.
Praveen? Yeah, James.
Joe, you can start the first.
Okay, Sir Joe is traveling. So we'll have the first session. For the first session to chair, we have Dr. Prabhanini Gupta, former president of the IAE Kerala chapter, and Dr. James Thomas, former secretary, and Dr. Muhudan from Thrissur. All three are welcome to this meeting. I think now they can set the ball rolling. The first talk, please. Can you put up the first talk?
Good afternoon.
Madam, all the talks have been pre-recorded. We have kept the time as 7 minutes presentation and 3 minutes discussion. And the delegates can ask questions using the chat box. I recommend them to use the chat box to ask queries.
Okay, so now am I audible?
Yes, ma'am. Yes, ma'am. You are audible.
Yeah, you are.
So I think we'll have the first case, the case of BSR. Shall we go ahead?
let all others mute so that everyone can hear what the speaker says. There will not be much.
Okay, should I make it mute?
Good evening, respected teachers. Today is my IAE webinar case. It's a case of Darwin theory of natural selection. A 63-year-old hypertensive non-diabetic male came with since 2 months. Functional class to begin with. Progressed to functional class 3 with no history of orthopnea, no history of acute pulmonary edema, no history of cardiac pain, palpitations, or syncope. Pulse rate was 96, BP was 134/80, bilateral edema was there, JVP was elevated with prominent V wave, a systolic trill was seen at third and left intercostal space, a 5 or 6 cholesystolic murmur with maximum intensity at third left intercostal space with bilateral crepitations. Investigations wise, except creatinine being high with EGFR of 33.3, rest of were okay. ECG showed actually features suggestive of evolved anterval MMI, poor average progression QS in V2 to V5, the QR in V1. Suggestive of evolved anterval MMI, posterior AVR northwest axis. X-ray showed florid pulmonary edema. This is post-procedure. And there was actually apparent cardiomegaly, but not a clearly. Echo showing a parasternal long axis view, dilated RV, LA. LV sub looks to be fairly well contacting. No RWMA seen according to the CP course method. In the parasternal short axis view, with the right posterior tilt, we can see some VSR noted, not even affecting fourth chamber view. We can see the same here. In the color Doppler, we can see here. And if it's a proper, slightly tilted again, you can see proper shunting of blood. The gradient was 60 millimeter of mercury. The distance was 1.56 centimeters, the defect size, and there was a moderate PAH. Silent MI seen 22% diabetics, but only 2.4 in non-diabetics. VSR generally used to be 1 to 2% of the presentations. Nowadays, it's come down to 1.17 to 0.31%. Prototype with thrombolysis will cause also lower incidence. As you see, according to the same data, the decreased incidence of VSR due to air flow return. It has a bimodal peak, 24 hours and 3 to 5 days. Independent risk factors like old age, female sex, and prior stroke and CKD are all issued. Present generally with STEMI or positive cardiac biomarkers, cardiac arrest, and higher P+, but it is not seen in our case. So generally, the transmural infarction. Anterior cause apical defects, whereas inferior and lateral will cause basal defects, results obviously shunting from LV to RV. Unpredictable hemodynamic duration is generally seen, and as well as the coagulative necrosis of the ischemic or tissue is generally this thing for the subacute one. But within 24 hours, there is a dissection of intramural hematoma or hemorrhage to the ischemic myocardium. So they are classified type 1, type 2, and type 3. Type 1 being the cyclic tear, type 2 being subacute presentation with erosion, and type 3 being with the aneurysm formation. Simple and complex are seen. Complex is seen with the serpiginous kind of thing. This A and C showing simple one, B and D showing complex. It was initially designed for device closure, but being a posterior and as well as thin reams, was deciding instead. Plan for VSR surgical closure, pre-op angio and LV angio here. Showing here caudal view showing lady deceased. Same again is epicranial showing proximal to mid lady diffuse disease. RCA showing a proximal showing a diffuse disease. Also a lady in RCA. LV angio. So here was not a clearly visible. When we went to hepatoclavicular view, the clear defect was seen. Opacification of the right. So surgical management was planned and left ventriculotomy and was obviously generally the norm in which most surgeons go about. Either Daggett and David procedures are generally used, either the Daggett being RV and LV suturing, whereas David is only all sutures plus the LV. This is the picture depicting that. In this case, we have taken up for the CTS team has taken up for surgery, which they have opened up ventriculotomy. This is initially opening ventriculotomy, 2 pictures. The apex, the defect was identified, patch was put. This is a David procedure which was done, and ventriculotomy was closed with a Teflon patch. Generally, acute MI with VSR, they generally manage to hemodynamically unstable patient, immediate surgery or ECMO delayed surgery. Percutaneous closure also we can attempt if the anatomy allows us and the defect allows us. Hemodynamically stable patient, larger VSR, closer monitoring with afterload reduction with pharmacotherapy and IVP or ECMO, and a delayed surgery after 7 days is generally better. Hemodynamically stable with small VSR can have to delay as long as possible in conservative management and percutaneous closure or delayed elective surgery. As we can see here, based on SCS data of surgery for surgical intervention, this is the largest data we have for the VSR closure surgical. If within 24 hours, 60% highest mortality is seen. If 1 to 7 days, it's 54%, whereas in 8 to 21 days, it's 30%. And if more than 21 days, it's 10%. So it shows as long as you delay, it will be better for the surgery. But patient might also not survive. You have to weigh the risk and benefit of that. In Custo 1 series, which shows, albeit being only 34 and 35 patients, if intervened at 1 to 7 days, 3.5 being the median, it's around 47% survival. If you don't intervene at all, it's 94% mortality. Based on the Thiel and al., this is a percutaneous closure device. Earlier closure device with patients in shock 88%. Later, with not in shock, 38% was the mortalities. So these are the major trials in percutaneous closure of ventricular septal rupture, showing again the same thing. Azinsa and Thiel et al. Are the maximum 30 and 29 patients subsequently taken. Earlier are 42% mortality and later 11%. In Thiel et al., as we discussed, 88 and 38% based on earlier, later, and as well as based on the hemodynamics. So this is a rare case where the patient actually survived. In our this patient has actually survived with currently recovering from surgery in heart failure. So it is a very interesting case. Thank you. And all as this patient also presented with the heart failure rather than actually myocardial infarction.
So
Yes.
what is?
Thank you.
What is the time delay between presentation and doing the surgery in this patient?
Good afternoon, ma'am.
Good afternoon.
Yes, ma'am. He actually initially presented with the heart failure. He was
No.
taken up for. Yes, ma'am.
When is his index MI?
Ma'am, there was no history of any cardiac pain or any myocardial infarction.
Yeah, that's what I understood. Okay. Okay.
So
when was his when did his dyspnea start and when did you get the patient and when did he go for surgery?
Ma'am, 2 months history of dyspnea was there. Wasn't for the last 15 days. So as he presented to us after 2 months, then as soon as he presented us, we took him for an LV angio and echo in 3rd day itself.
Yeah, very unusual. Third day you did, and how soon after your angio the surgeon took up?
Then actually after the procedure, ma'am, he went into pulmonary edema after the LV. Yes, ma'am. So he was decongested, then discharged. Within 10 days, he was taken up, readmitted and taken up for the procedure.
10 days he was readmitted. Oh, that's very dramatic and good. Okay. Then just one more thing. What was the size of the VSR and what was the gradient on echo? 1.56 centimeters with the just actual defect, but with the thin rims, it was around up to 3.23 centimeters. Very big VSR. And what about the gradient? 60
millimeter of mercury.
Oh, that's a rather unusual thing. Okay, so anyway, we have done a sort of statistical study, and we found if the gradient is more than 5,
yes, sir,
the patient can survive for a while. But other people have found that if the VSR is bigger than 1.5, the patient should go only for surgery. So anyway, it looks like you have done a very dramatic thing, and the patient has survived. Very good. Congratulations. Yes. And he doesn't have any hemolysis?
No hemolysis, ma'am. He had sepsis after the procedure. He had a gastroenteritis.
Okay. But you are treating him and he's better.
Yes, ma'am.
Okay. Does anyone else have any questions?
Whether
I have to look at the chat or what?
Suresh sir has asked a question.
What is that?
Additional information do we gain from an LV angio in a case like this? Nagendra, can you?
Yes, sir. If there are multiple VSRs, generally surgeons ask for this if you look for any multiple VSRs, smaller defects to see.
Yes. Yeah. No, and I think it's, agreed.
May I make a comment? Madam, may I make a comment?
Yes,
sir.
Sure. Go ahead.
The surgeons actually insistence that we should have an LV angio just to see for any additional VSRs which we miss. That
No,
is one reason why.
LV angio is indicated, definitely.
Uh,
Definitely.
that part I
Before
was
going in
not
for the
very
procedure, they'll be more comfortable with an LV angio.
Yes. It is mandatory to see the LV function.
Vijaya, sir,
So you are muted.
LV function can be.
I'm listening.
Yes, sir.
No.
Do
After
you
seeing,
insist that you do angio?
after seeing such a large ventricular surgery defect and the presentation as primary as left ventricular failure, you still want to look for additional defect. Anyway, you are opening up. You can fill the LV and see if there are additional defects at the time of surgery. After portion of the made defects, you're going to fill up the LV and look for additional defects. The LV,
Your point is right.
LV angio, which often is a washout because a large sample defect. I find it very difficult to identify additional smaller.
Okay, sir. That sounds reasonable. That sounds reasonable.
Mohandan sir, any comments?
One point which I would like to say is if VSR goes on without much of issues or get controlled with cardiac failure after 3 weeks, the patient is likely to survive more. Chances of survival is more. And one more is if you have a VSR which is distal to the moderator band, that is apical to the moderator band, they also have chances of better survival than the VSRs which are proximal to the moderator band.
So that's a good
That's-
point.
What was the TR jet in this patient?
47 millimeter of mercury.
47 millimeter. Okay, so the patient was being slightly, the blood flow was being slightly controlled by the
Madam?
development of pulmonary hypertension. So it is
Yes.
obviously not very acute. No, it was
Yes.
acute. It was acute. It started probably developed within
Shall we go to the
2
next
weeks
case?
before presentation.
Yes.
Shall we
okay.
move on to the next case?
Yes, I was about to ask that. Can
Yeah,
we
next
move on to
case.
the next case?
We have light at the end of the tunnel by Dr. Nikhil MK from Government Medical College, Kottayam.
Good evening, respected teachers and my dear colleagues. I'm going to present a rare case that presented to our department and how we managed it. I would like to call this case light at the end of the tunnel. And it's about a 5-year-old girl child born out of a non-consanguineous marriage with no relevant prenatal or perinatal history, was referred in view of incidentally detected systolic murmur. Her X-ray showed no cardiomegaly but a mild RA enlargement. And when we went on to do an echo for this patient, in the fourth chamber, we noted mild RA, RV enlargement. There was also an AST, a small AST in this patient with left to right flow. And the modified subcostal short axis view showed a hypoechoic circular lesion in the upper part of the IAS where the SVC was draining into the RA. And we noted continuous flow through both systole and diastole in this lesion here. So we went on to do further views, and the same lesion could be seen as a fistula tracking from the LM, going between the aorta and the LA, and finally draining into the RA in the parasternal short axis view. And a modified 5-chamber view also showed the same lesion tracking between the aorta and the LA and going into the RA. So the color flow, we can see there is continuous flow through the fistula, and it is flowing to the RA. And the same can be seen in the apical 5-chamber, modified apical 5-chamber view too. It's a clearer picture here. So CTCA was done for this patient as we were planning for device closure in this patient in view of dilated RA-RV chamber enlargement in a patient with a fistula. So coronary fistula, and the CT coronary angiogram showed a LNC of size 6.5 millimeter and a 6.1 millimeter large vessel arising from the left main before bifurcating and coursing posteriorly between the aorta and LA and draining to the RA. It was approximately 6.4 millimeter in size. There's a mid narrowing and a distal 6.5 millimeter with an LAD and LCX which was normal. So we can see here that during the LM injection, we can see a fistula transversing here and finally ending opacifying the RA. LAD and LM are seen to be normal, following which coronary, we went on to wire the lesion. That is, a fine cross microcatheter was introduced with the BMW wire into the left coronary artery. It was passed into the coronary fistula, then into the RA, and finally into the IVC, and an AV loop was created, as seen here. And going on, we placed the coronary wire with the Terumo wire, and from the right femoral axis, it was snared and it was pulled out, and Mullin sheath was introduced in the femoral wire, and an injection was taken. And this is that injection showing left main fistula from the left main coronary artery into the RA with the central constriction. And a device was Oplonics device was selected for this patient of size 6 to 8 millimeter, and the ductal occluder was used. The Oplonics ductal occluder was deployed after assessing the size. Post procedure, there was no flow across the device. The post procedure echo here shows the device in position and the left coronary artery above it, which is a bit distorted. The parasternal short axis view shows the enlarged left main coronary artery and the fistula which we noticed earlier with the device in situ. This is a still image of the same. And we can go on to see there is no flow across the device. There is adequate flow across the left main coronary artery. So coronary cameral fistula are uncommon anomalies with a prevalence of 0.05% to 0.25% of all CAGs. So male to female ratio is 1:1. Most commonly known as RCA. Most of them are asymptomatic and detected incidentally in adulthood usually. And other presentations include ischemia that occurs distal to the fistula due to coronary steel phenomenon and heart failure. The indications for intervention, the class 1 indications according to ACC AHA guidelines of 2020 are MI, arrhythmia, ventricular dysfunction, chamber enlargement, and endarteritis. And the complications of the procedure include coronary artery spasm, ventricular arrhythmias, coronary perforation, coronary dissection, and ischemia from thrombosis or improper position of the device. So that is all. Thank you.
Did the patient have any fresh ECG changes after the procedure?
No, ma'am. She had no fresh ECG changes. She
And
was
she-
asymptomatic from the beginning itself.
But
And,
was
there
she
are
under anesthesia
for
when you were
the-
doing it?
She was under anesthesia, ma'am.
Right, okay. Then, okay, continue. Tell me the follow-up of this patient on this day 1.
Ma'am.
No, did she have ECG changes, any troponin elevation?
There was no troponin elevation or significant ECG changes after the procedure, ma'am.
Okay.
Her initial presentation itself, she was asymptomatic. She was detected to have a murmur and was referred here. And there were no features of heart failure in this patient. Echo showed RA-RV dilation and a large fistula. It was about almost the same size of the LM, and hence we planned procedure intervention for this patient.
No, I agree fully. Actually, it's a wonderful case and done wonderfully. Actually, both the cases are very good. I mean, very good quality. Actually, they should have been in the award session, but that I'm not the organizer, so I can't say anything. But what I'm asking is, when you were planning this procedure, what were your considerations? Like, when you're going to close an AV fistula, you might be afraid that something may happen to the LM. So what were your thoughts at that time? Just to share with the audience, because left main is a very big vessel. Usually we see AV fistulas from the circumflex or RCA. So this is an unusual thing. So tell us your thoughts or your
Yeah,
department
in this
thoughts.
case, we can clearly see that the fistula continues after giving LAD and L6 from the LM
Yeah.
as an arch. We had enough leeway for us to place the device. So it was safe to place the device
Yeah.
more distally,
Okay.
away from both LM and L6 in this patient.
Okay.
I mean
So-
LAD and L6 in this patient. So
just one more question. Did you give any antiplatelets after the procedure, or you just left the
we are giving aspirin and cloplet for 6 months, and we are supposed to be planning on giving aspirin for a period of 1 year.
Okay. Okay. Any other questions? Very good case.
One thing which can happen with these cases are sometimes post-procedure severe hemoglobinuria can occur in the hemolysis, and because the residual shunt, minimal residual shunt can last for some days and then finally settles. One case which we have done actually for an RSOV, the patient had persistent hemoglobinuria, I mean hematuria for many days, including rise in the creatinine, but later on it settled. That is one thing.
That
which can
case,
happen.
I remember seeing you present it, but I just wanted to know, in that case, did you re-intervene or just waited?
Just waited.
Okay. Yeah, I've seen that patient recently. He's doing very well. Very
Yeah.
nice.
Shall I go to the next case?
Thank you. Thank you.
Good afternoon. I am Dr. Manju Bhargav, cardiology resident from Trivandrum Medical College. I am going to present a case of prosthetic valve dysfunction. Coming on to the brief history, she is a 41-year-old lady post mitral valve replacement for rheumatic heart disease, severe mitral stenosis in 2022 with St. Jude bileaflet valve. She was on regular follow-ups with periodic echo and on acetrom with INR of 2.26 with a recent follow-up a few days before admission. She presented with worsening breathlessness, functional class 3, orthopnea of 2 weeks duration, and acute febrile illness of 1 week duration. A clinical suspicion of prosthetic valve dysfunction or infective endocarditis was made. At presentation, the BP was 210 by 120 millimeter of mercury with a sinus tachycardia of 140 beats per minute. She was having bibasal crepitations, no audible murmurs. The INR at admission was 1.42. She was having elevated counts with neutrophil predominance and had a severe anemia of 8 grams. So at the admission, this was the echo. So what we are seeing in the echo is a parasternal long axis view showing dilated left atrium, and we can see a left ventricle, LVOT, and right ventricle. So this is a prosthetic mitral valve. Actually, we are able to see the prosthetic mitral valve. However, the valve leaflets are not clearly imaged. So here I have taken the focused still image of the echo where we can see a hyperechogenic structure just above the mitral valve of the size is around 1.35 centimeter. It can be a possible thrombus, but we are not sure. So the M mode across the aortic valve and the left atrium shows clearly that the LA is dilated and the aortic valve closure is normal. And the M mode of the left ventricle at the papillary level shows normal LV dimensions and good LV ejection fraction. So this is the apical 4-chamber view. So here we are seeing the prosthetic mitral valve shadow. The mitral valve seems not to be opening well. Echogenic structure in the medial annulus is seen, and that structure is mobile. So that can be a possible thrombus. So we are able to suspect thrombus in both parasternal long axis view as well as the apical 4-chamber view. So this is the continuous wave Doppler taken across the mitral valve. it shows a mean gradient of 34 millimeter of mercury, and we can come to an assumption that prosthetic valve is dysfunctional. So again, we can see severe tricuspid regurgitant jet, and there is severe PAH of 58 millimeter of mercury. So what did the echo reveal till now is prosthetic valve dysfunction, a visible thrombus over the prosthetic mitral valve, a concerning gradient of 34 millimeter of mercury across the mitral valve, anemia, tachycardia might have influenced the gradient as well, good LV ejection fraction, and now we are not able to comment on the prosthetic valve vegetation. So after the echo, so these were the concerning issues. One is she has a low INR, which might have led to prosthetic valve thrombosis. The three good options available in front of us were thrombolysis or an emergency surgery or just heparinization. Actually, initially heparinization was done to achieve optimal APTT INR. Along with that, we gave IV diuretics, IV iron for anemia correction, IV antibiotics for 1 week. So after the 1 week, the mean pressure gradient decreased to 19 millimeter of mercury from 34. So here, the settling of the heart rate, correction of anemia might have led to the reduction in the gradient as well. So fall in the gradient does not equate to increase in the valve area. So the next thing was she became symptomatically better, afebrile as well. Functional class 3 became functional class 2. The next thing what we did was a cine fluoroscope. Here cine fluoroscope, if we see carefully, we can see one of the valve leaflet is stuck, whereas the other valve leaflet is opening properly. So after 1 week of admission in the ICU, we decided to go for thrombolysis. So injection streptokinase 1.5 lakh units over 30 minutes, followed by 1 lakh units per hour for 12 hours was administered, and the thrombolysis was uneventful. Serial echoes were done post thrombolysis, and at the end of the lysis, the mean pressure gradient reduced to just 7 millimeter of mercury. Actually, in some of the echoes, the gradient had even decreased to 3 millimeter of mercury as well. So the post-lysis fluoroscopy image is we can see in the normal excursion of both the valve leaflets. If you compare with the previous fluoro, one leaflet was stuck, but now post thrombolysis, both the valve leaflets are normally open. So this is a post thrombolysis echo. That's a 4-chamber view. So what we can see here is both the valve leaflets opening considerably well. We can see both the valve leaflets being mobile. So the pressure gradient taken across the mitral valve, it shows a mean pressure gradient of 7 millimeter of mercury. So the discussion part is, it is worth noting that streptokinase carries a high risk of bleeding compared to low-dose tissue plasminogen activator, which is a lower incidence of complications due to slow lysis and greater fibrin selectivity. Although surgery has better outcomes in terms of complete success rate and lower complications, thrombolysis has lower mortality rates as reported by Dr. Karthikeyan et al. To prevent thrombosis of prosthetic valves, adequate PT-INR values are required and echocardiographic follow-up is recommended. In the case of prosthetic valve dysfunction, cardiac CT is a better imaging modality to differentiate between pannus and thrombus. In this case, cardiac CT was done and it just revealed a thrombus and not a pannus. To conclude, prosthetic valve thrombosis is a major concern for cardiologists, but early diagnosis and prompt treatment can improve outcomes. Low-dose tissue plasminogen activator has shown excellent outcomes with minimal thromboembolic and bleeding complications. If unavailable, streptokinase can be used as a thrombolytic agent. Patient education on regular INR checks and medication adherence is also crucial for preventing recurrences. Thrombolysis should be considered whenever emergency surgery is not feasible according to ACC 2020 guidelines. However, emergency surgery is recommended for patients with dyspnea functional class 4 due to obstructive thrombus or recent onset embolic event in critically ill patients according to ESC 2021 guidelines. The take-home points is this is the algorithm for the evaluation of a prosthetic valve thrombosis, which depends on the size of the thrombus, the location of the valve, and the INR targets for various valves at various sites has been mentioned. Thank you.
Very interesting case. Obviously, you have gone through the guidelines. I'll tell you a sentence which I read from the guidelines and you give me your opinion on that. I personally think that's a silly part of the guideline. What they have said is prosthetic valve thrombosis and prosthetic valve endocarditis can lead to cerebral embolism. Before starting heparin, it's better to have a CT scan of the head to make sure that there is no embolism to the brain. So, according to me, prosthetic valve thrombosis is a big emergency and you have to deal with it fast. What's your opinion on that?
Good evening, madam.
Good evening. Did you understand my question?
Yes,
Did
yes,
you
madam.
see
Yes,
that
ma'am.
in the
I understand.
guideline? You've read the same guideline. So, did you see that
Yes, madam.
sentence? So, what's your
Yes,
opinion?
madam. Ma'am, CTA head was not considered in this case. It was not done because clinically she was no signs of
All right.
IC bleed or anything. So we proceeded with heparinization. But one thing is, actually, Suresh sir asked a question in the general chat, ma'am. Sir asked whether T was considered in this case to differentiate between a vegetation and a thrombus, ma'am. Actually, T was not done in this case. So, and actually blood culture was done and blood culture was negative in this case. So we provisionally ruled out infective endocarditis.
Okay. Vigilant sir, do you have any comments sir, on this case? So, you're mute. Mute.
When you have a large thrombus, your question is about giving streptokinase or heparin. What's the main question?
Sir, if there's a large thrombus, actually it is better to heparinize because streptokinase will cause embolization of the thrombus.
Exactly.
And
that's the point I was leading to.
Okay.
Streptokinase is a risk of fragmenting the thrombus there and discreting embolization.
Yeah.
Initially, that was very, very dreaded the streptokinase.
Okay. Yes, sir.
Madam, since we are okay, Mughal sir, please.
Yeah, was a fluoroscopy done in the beginning itself or only after 7 days?
sir, only after 7 days fluoroscopy was considered, sir.
Okay.
That was actually not fair, but yeah, we missed it.
It is
Very sick.
better to
Very
see in a fluoroscopy. The movements will be better seen in a fluoroscopy than an echo, or TE would have been better to see valve movements. But in a patient who is sick, TE will be a little difficult. Fluoroscopy will be the easiest one.
Yes, sir.
So shall we move on to the next case since we are slightly running behind time? So the next case is Osaki dilemma. An interesting name. I think it's being presented by Dr. Vivek Thapa from Government Medical College, Kottayam.
Good evening, respected teachers and my dear friends. Today I'll be presenting on my case which I have titled the Ozaki dilemma. So before coming to the case, just a few lines about the Ozaki procedure. The Ozaki procedure is a relatively new surgical technique where we construct a new aortic valve using autologous human pericardial valves. So for doing this, we take a measurement of the commissural length and we take another measuring template, and then the individual human pericardial valves are cut out and they are sutured to the annulus. So we have 3 individual cusps, and the final result looks like this, which resembles a windmill in the closed position, and this is in the open position. Now, one difference between the native valve and the new valve is that in the native valve, the coaptation point is lower compared to the commissures, whereas in the new valve, the coaptation zone has been lengthened so that it reaches at the level of the commissures for better coaptation. Coming on to the case, it's a case of a 65 years old female with diabetes, hypertension, dyslipidemia, hypothyroidism. She was diagnosed as a calcific aortic valve disease with severe AS, mild AR, mild MR, good LV systolic function. On June 28, she underwent the Ozaki procedure. Following that, it was an uneventful post-operative period, and she was discharged on the 6th post-operative day. However, after 1 month, she was readmitted with pulmonary edema. And on auscultation, there was a early diastolic murmur in the left third intercostal space. This was an initial X-ray, which is showing pulmonary edema with consolidation and collapse of the left side of the lung. So she was initially treated as LRTI with antibiotics, and also also diuretics were given. And transthoracic echo was taken initially. Now this is in the apical 5-chamber view, where we can see significant turbulence in the around the aortic area, and also suggestive of some early diastolic AR. This was in the CW. Now CW, there was when we took the CW, we noticed a peculiar unique pattern which we had never encountered before. Here in this view, we can see that there is a dense AR jet, which is limited to the initial 1/3 of the diastole. And following that, there is an abrupt cutoff in the AR. And this was more prominent during when the heart rate was either slow or normal, compared to when the patient had tachycardia. When the patient had tachycardia, the AR jet occupied more of the diastole. So this was the quite a unique feature. So this meant that there was a dense AR, which was just confined to the only the initial 1/3 part of the diastole only, with no AR in the later part of the diastole. So following this, we have taken a esophageal echo. Now these are the stills from the transesophageal echo during late systolic, early diastolic, and mid diastolic frames. Now, mainly during early diastolic phase, there was an interesting phenomenon. There was a dense AR jet, which was occupying almost the entire width of the LVOT. But however, just a few moments later in the mid diastole, we can see that the AR jet has abruptly been cut off. So here we can see the valves have coapted here, whereas here the valves have not coapted. So what we could infer was that the valves were taking a longer time to coapt. They were not coapting in early diastole, but rather they were coapting in the mid diastolic period. Now in this still in this video, we can see the valves clearly. Now in this picture, we can see that the coaptation is actually happening at the middle portion of the valve, whereas the distal portions of the valve are we can see that they are relatively long and redundant, and they are not coapting actually. They are still staying apart even when the middle portion of the valve is coapted. So if we take a slow-mo, here we can see that the distal portions of the valves are taking a longer time to come inside. Here the middle part of the valve is coming together, but the distal portions are still wide apart. So this could explain the cause for the late coaptation of the valves. So the late coaptation could be because of the longer length of the valves and the distal portion of the valves not coming together. In the later portion, because of the Venturi effect and because of the blood filling the sinuses, the valves have coapted. So a few take-home points. Now this case was presented to highlight an unusual AR jet following aortic valve repair. Early diastolic AR following Ozaki repair has not been mentioned much in literature, and it may be a result of could be due to valve sizing or valve preparation or other operative for the unknown reasons. And it can be easily missed in routine screening echo if the heart rate is low or normal. And tachycardia due to any cause can actually lead to rapid clinical deterioration and hemodynamic instability. Now, this is the opposite of what is expected in other etiologies of AR, and this can have significant clinical implications. Because in other causes of AR, when there is tachycardia, actually the patient condition improves. But in our case, when there is tachycardia, the patient condition rapidly deteriorates. So this can have significant clinical implications. So the main purpose of this presentation was to highlight this point. Okay, thank you.
This Thank you. Very interesting case. See, Ozaki procedure is done either in children or in adults. In children, it's done because the annulus is very narrow and you cannot have a valve of that size. What was the annulus size in this patient and why was Ozaki procedure thought of? Are you not online?
I think we can't see him.
I think Madam Vivek has some problem with the video part, so he's not joined, I think. Trying
But
to
let
join.
him be on
No, he's
sound.
not able to log in, madam.
Okay, then I'll just say a few words about Osaki and then James can also say. So Osaki procedure was originally done for children. So unless usually if the annulus is 19 millimeters, a prosthetic valve will not sit there. So we don't know why they did it in this case. But there are a lot of cases of Osaki procedure in adults also. Number two is they've compared Osaki procedure with Batista procedure where bovine pericardium is used and its glutaraldehyde preserved. And they claim by literature it's better. Even then, Osaki procedure is a good procedure with good results. There are series. One series is published in 2021. Okay. James, any comments? Sir, Vijayan, sir?
Madam, it's a wonderful case.
It's a wonderful case.
Beautifully demonstrated.
Yes. And they demonstrated the hemodynamics very well.
Very well.
Vijayan, sir, do you want to say something, sir? Sir, can't hear, sir.
I'm sorry, I've read about this procedure. I have not read any series.
Oh, okay, sir. Okay. Okay, sir. There's a series. It's not easy to download it. I got it from ResearchGate. ResearchGate. Yeah. Okay. I think maybe we can go to the next case. Are we very much behind time?
But I think we are slightly behind time.
Okay,
We'll move on to the next case.
You
A rare
go
case
to
of,
the next case.
A rare case of ruptured sinus of Valsalva by Dr. Kiran Kumar Devashetty from Medical College, Trivandrum.
Good evening, respected teachers and my dear colleagues. Today I am going to present a rare case of ruptured sinus of Valsalva aneurysm. Brief clinical history. A 61-year-old male fisherman presented with sudden onset of chest pain on exertion since 1 month, breathlessness on exertion since 1 month, and palpitation since 1 month, bilateral leg swelling since 3 weeks, and past history of similar complaints 12 years back, for which he underwent open heart surgery. On examination, pulse rate was 72 per minute, irregular, varying volume, predominantly high volume, non-collapsing, with no radial or radiofemoral delay. All peripheral pulses are palpable. Blood pressure was 126 by 70 millimeter of mercury. Jugular venous pressure was elevated 5 centimeter above the clavicle with absent A wave and prominent V wave. Apex B2 was felt in left 6 intercostal space, 3 centimeter lateral to mid-clavicular line, forcefully in character. A grade 2 left parasternal heave was present, and first heart sound was varying in intensity. Second heart sound, A2, P2 was normal split and normally moving with respiration. A2 was normal intensity and P2 was loud. A grade 4 by 6 high pitch continuous murmur was best heard at the left lower sternal border and also heard all over the precordium. A parasternal long axis view, transthoracic echo, 2D view showing dilated LA, LV and RVOT with normal appearing aortic valve and mitral valve. In second image, you can see color Doppler across the aortic and mitral valve showing mild aortic regurgitation. Parasternal short axis view, transthoracic echo, 2D view showing a echo dropout between aortic sinus and right atrium. In second image, you can see color Doppler across the aortic sinus with the left to right shunt across aortic sinus to RA, suggestive of RSO to RA. 4-chamber transthoracic echo, 2D view showing right atrium and right ventricle are dilated with interatrial septum slightly bulging to left atrium. Mitral and tricuspid valve appears to be normal. In second image, you can see a turbulent flow across the aortic sinus to RA, suggestive of RSO to RA. 5-chamber transthoracic echo, 2D view showing echo dropout between aortic sinus and right atrium. In second image, you can see a color Doppler across the aortic sinus with left to right shunt from aortic sinus to right atrium. Transesophageal echo at short axis view showing echo dropout between aortic sinus and right atrium. In second image, you can see color Doppler across the aortic sinus with left to right shunt from non-coronary cusp to right atrium. A patient was planned for device closure of the RSOV. Right femoral artery and left femoral artery access was taken. A 6 French pigtail catheter was introduced into aortic sinus to confirm the site and size of the RSOV. And 8 French JR guide catheter along with turbo wire was taken to aortic sinus, and RSOV was crossed with turbo wire 0.035, and guide was then crossed over the wire into the right atrium. The wire was removed. Then Konark MF BST occluded device 10 into 8 mm was loaded into the catheter. One disc of the device is released into the RA, and then entire system was pulled back into the aortic sinus, and other disc was deployed. After that, aortic root angio was taken, showing significant leak across the device. So it was decided to retrieve back the device, but it has embolized to the right pulmonary artery. So device was retrieved percutaneously using gooseneck snare. First image, you can see aortic root angio showing windsock deformity with wide aortic end and a narrow right atrial end. In second image, you can see aortic root angio with the device across the RSOV with significant leak across the device. And third image, you can see the device has embolized to the pulmonary circulation, that is right pulmonary artery, which was retrieved through percutaneously, transcatheter, percutaneously using gooseneck snare. Take-home message, RSOV is a rare congenital heart disease. Presentation varies from asymptomatic to acute heart failure, which can rapidly worsen to cause death. Although surgery is the gold standard treatment, percutaneous transcatheter closure has now become equally efficacious with fewer complications. Embolization of device is one of the complications, and cath lab should contain hardware to deal with such complications. Thank you.
See, theoretically, you should have used a balloon to size the RSOV communication. But probably you may not have had sizing balloons. Like I remember we never had any sizing balloon. So if the sizing balloon showed a very big RSOV, probably you should not have attempted a device.
Hello.
Hello. Yeah. Can you hear?
Yes, ma'am. Yes.
Did you use a sizing balloon before putting the device?
Yes, ma'am. Now I can hear, ma'am.
Did you use a sizing balloon before you put the
No.
device?
No, ma'am. We have not used a sizing balloon before putting the device.
Actually, you should have used a sizing balloon, because sometimes when you use a sizing balloon, the defect
No,
is
ma'am.
actually...
We have not used a sizing balloon before.
No, when you use it, you will find the defect is bigger than you anticipate. So you can prevent an embolization. That's the situation. Okay. Anyway, it's a very interesting case.
Ma'am, your voice is not clear, ma'am.
Not clearer. Oh, it's a very interesting case. And does James have any? I was saying that you should have used a sizing balloon before putting the device, so that you could have tried a bigger device. And but it's very commendable that you could retrieve the device. Can you hear what I'm telling? Something wrong with my internet. James, you please talk. Why is my voice not heard?
No, madam, your voice is clear and.
Okay. James, you can ask something if you want.
No, madam. Mukundar sir, any comments?
Nothing. I think doctor is not there. He's not logged in. He has come back, huh?
Yeah, he's there. Dr. Kiran
okay,
is
Dr.
here.
Kiran is there. Okay. So, what was the procedure after that? After retrieving the device, did you reattempt it or send for surgery?
No, sir, no, sir. We have not reattempted, sir.
Send for surgery. And what was the size of the angiographic size of the defect? Are you able to hear me? I think James he is not able to hear. So we'll go to the next case. And
Sir, okay, Dr. Kiran, can you please answer the question?
Yes, sir. Sir, I have not heard the question, sir.
what is the size? What is the size of the defect and the RA side? What is the size of the defect in the RA side? Angiographically. It's okay.
Voice is not clear.
Okay, there may be some problem with the internet.
Sir, defect size was 6.
Kiran is having some internet.
Sir, defect
We'll
size
move
was.
to the next case.
Okay, so I
We'll
think
move
we'll go to the next case.
Yeah,
We'll go to the next case.
IoT and it was 6 mm, sir. RA side it was around 4 mm.
Okay, okay.
The next case is a case of stuck aortic valve prosthesis. Stuck aortic prosthetic valve. By Dr. Anwar.
Good evening all.
Hospital.
I am Dr. Anwar from VC Heart Institute, Kochi. Here I am presenting a case of a 28-year-old male. He is a non-case of rheumatic heart disease with moderate mitral regurgitation and severe aortic regurgitation, who had underwent a double valve replacement in 2013 with a St. Jude 23 millimeter St. Jude valve in aortic position and 27 millimeter St. Jude valve in mitral position. He was on regular medication and was asymptomatic. He was on oral anticoagulant also. Now, for past 3 days, he presented with dyspnea on accession, orthopnea, and chest discomfort. On examination, he was dyspneic and tachypneic with blood pressure of 100/60 millimeters of mercury, and pulse rate was regular, and rate was 80 per minute, with first and second heart sounds loud metallic in character, and ejection systolic murmur was heard. Routine blood investigations were within normal limit, except for PTNR, which was 1.5. ECG showed normal sinus rhythm with features of left ventricular hypertrophy, and X-ray showed pulmonary venous congestion also. This was the X-ray, which showed good LV systolic function, concentric LVH, with prosthetic valve in mitral and aortic position, and also there was moderate aortic regurgitation. And the gradient across the aortic valve, mean gradient was 96.5 millimeters of mercury with Vmax of 5.9 meter per second. And across mitral valve, the mean gradient was 13.2 millimeters of mercury with Vmax of 2.04 meter per second. And in St. Jude valves in aortic position, for a 23 millimeter valve, the acceptable Vmax is 3.5 meter per second, and for mitral St. Jude prosthetic valve of 27 millimeter, the acceptable Vmax is 3.1 meter per second. And we did a transesophageal echo also, which showed prosthetic valve across the aortic position, which is not functioning properly. And we ruled out any thrombus. And this was the fluoroscopy on the day of admission, which showed 2 leaflets, of which one is moving properly. The second one is stuck in open position. So here we have a case of stuck prosthetic aortic valve with aortic regurgitation and increased aortic gradient. We decided to thrombolize this patient with streptokinase, and next day the fluoroscopy showed similar picture, that is one leaflet is moving properly, other one is still not functioning, not moving properly, and the gradient significantly came down. The mean gradient across aortic valve was 26.6 millimeters of mercury with Vmax of 2.9 meter per second, and the aortic regurgitation also came down. And on we extended the thrombolysis for 24 hours for one more day, and this total 48 hours we gave streptokinase. And on fourth day, this was the fluoroscopic picture. Here we can see both the leaflets are moving, and the gradient again came down to 23 millimeters of mercury with Bmax of 3.2 meter per second. And there is only mild aortic regurgitation. This was the echo taken 2 weeks after thrombolysis. The mean gradient was 24 millimeters of mercury and Bmax was 3.1 meter per second. And he symptomatically improved. And so here we have a case of stuck prosthetic valve in open position with increased gradient and aortic regurgitation, which became normally functioning valve after 48 hours of streptokinase thrombolysis. Thank you.
So very, very interesting. Could you hear the valve sounds better after the thrombolysis?
Yes, ma'am. It was heard better.
When you, before the thrombolysis, were the sounds muffled?
It was muffled, ma'am.
Oh, okay. So the topic is open for the other chairpersons. James? Mukundan?
Very good case. Because you extended a thrombolysis that gave the better result. Probably after
Yes,
1
sir.
day, you did not get the expected
Yes.
result.
Yes,
And
sir.
in the TEA, were you able to see a thrombus?
We ruled out presence of a large thrombus.
Okay. Okay, that is the most important thing because
Yeah.
if
Yes,
there
yes,
is a
sir.
large
If
thrombus,
there is a
then
large thrombus which is pedangulated after thrombolysis, which can
yes,
embolize.
embolize.
Yeah, yes, sir.
Okay. Very good case. James.
Thank you.
We go to the next session. I think that is the 6 cases
Just one
we had.
comment from Vijayaraghavan, sir. One comment from Vijayaraghavan,
Yes.
sir. Sir,
Sir, you're muted, sir.
This case,
yes, sir.
see, persistence with the thrombolytics for more than 24 hours often keeps patients. We've seen it many times. But monitoring of the metrology has been very strict and very carefully supervised.
Okay, thank you, sir.
Shall we conclude the session?
Yes, sir. I think we can conclude the session.
Yes.
We thank all the presenters.
Yes, you can. You can. You can.
Presenting these beautiful cases. So I think we can now move on to the next session. I think we got like one keynote lecture. We got a very well-known speaker. We got Dr. Bijilal S. from Srijitra. He is going to talk on post-TAVI echo evaluation newer concepts. And for chairing the session, I invite Dr. Ashraf SM, Dr. Shafiq Matammal, and Dr. Abhilash SP. Over to the chairperson.
Thank you. Thank you. Now we have a very good lecture on the post-TAVI echo assessment and future trends. None other than our own Dr. Bijilal. Over to Bijilal, please.
Thank you very much to Shifa sir and other organizing team for giving me this opportunity. I hope I am audible.
Yes, yes.
Yes, sir, you're audible.
So periprocedural echocardiography in TAVR is my topic for discussion. Actually, sir wanted me to talk about the post-procedural assessment. That is very less. So I changed the topic a little bit to periprocedural echocardiography in TAVR. So this is my disclosure. Actually, valve replacement is essentially an angiography guided procedure. It is not a echo guided procedure, whereas valve repair like mitral clip and all are echo guided procedures. In this era of minimalistic TAVI, where TAVI has become something like a PCA with a little more little more emphasis on pain management. So the role of echo and TE has come down in this current era. But still, echo and transthoracic echo and transthoracic echo both are important in assessing the evaluation of hemodynamic instability during procedure, which is not uncommon. It's also important in assessing the implant depth and gradients post-procedure. But overall role of echo in valve replacement is little limited during procedure. We know about the pre-procedure echocardiography, where the diagnosis is diagnosis of aortic stenosis, the diagnosis of the assessment of LV function, everything is done by echocardiography. And it's a great screening tool to assess the feasibility for TAVR as well as assessing the score. And it helps in deciding which patient is suitable for SAVR, which patient is suitable for TAVR. Suppose the patient has some features like a dilated ascending aorta, associated primary mitral valve disease. These patients may be better off with a SAVR rather than TAVR. Whereas if patient got severe LV dysfunction, other comorbidities, then that patient may be better suited for TAVR. And you know, we have to exclude endocarditis in all these patients. So pre-procedure echocardiography, I don't need to emphasize, it's a must. But coming to the intra-procedure echocardiography, procedure guidance by TE, this used to be the practice 10 years back. But in this era, intra-procedure guidance by TE, role of TE during procedure is limited. It is important in selected conditions like, for example, this image you can see a septal bulge. So in this patient, we have to keep the place the valve higher up. Like similarly in these two patients also, you can see that there's a process in the mitral position. So it should not interact with the mitral processes. So we need high implant in these situations like the septal bulge, presence of mitral valve processes. In this situation, TE during procedure may be helpful. But to emphasize, it is useful only when you are considering a self-expanding valve. It is not very useful in a balloon expander valve, because in balloon expander valve, you know, it is one go where there is no chance of recapture or redeployment. So intra-procedure TE guidance is useful in select conditions when you are using a self-expanding valve. So this is very easily understandable pictures to assess the implant depth. The implant depth of an SCV should be 3 to 5 millimeter from the bottom of the aortic annulus. You guys see that this is a deep implant, whereas this one is a very shallow implant. These two should not be accepted. These two are not acceptable. So TE during procedure is helpful in assessing the implant depth, but it is useful only in selected patients. It is indicated only in selected patients, even though it is useful. Why is it so? It is because it is a invasive procedure. Prolonged TE needs intubation. So in this era of minimalist TAVI, doing TE in all patients is not probably indicated. What you can do is definitely is a good tool to have it in your lab, especially when you are doing your early career and all high-risk patients. It may be good to have TE on table. And this on special role is in presence of LV thrombus. LV thrombus is a contraindication for TAVR, but sometimes these patients this may be the only option available to these patients. So in selected patients with patients with LV thrombus, presence of a 3D TE during procedure help us in reducing the interaction with the system with the LV thrombus. Whereas that is not the case with the transthoracic echo. It is non-invasive, and only issue is that someone may get a little bit radiated during the procedure. This must be available in all cath lab, and it is extremely important in evaluation of hemodynamic instability during procedure. This hemodynamic instability could be due to pericardial effusion. Sometimes you will see global LV hypokinesia, which suggests that this patient possibly the result of prolonged pacing. Sometimes we see new Walmore abnormality and patient hemodynamic unstable, suggesting coronary occlusion. These systems can interact with the mitral cord, produces severe MR, produces hemodynamic instability. So it is a very important tool in assessing hemodynamic instability during procedure. Suppose we don't see any of them, but still the patient is hemodynamically unstable. Look at the IVC, look at the LV volume. Let's say abrupt reduction in LV volume. Suppose the IVC is collapsed. The patient may be bleeding from the groin side. I'll show you one case. This patient is an elderly lady with severe aortic stenosis. We implanted the valve. At this point, she developed severe hypotension. We did an echo. This is new onset severe MR, and we can see valvular abnormality of the inferior valve. So angiography was done. It confirmed RCA occlusion. So the valve was pulled out, and patient became hemodynamically stable. So we did a coronary angiography, put a stent and deployed the valve. Got a good result. And this is the echo post procedure, previal MR, and the valvular abnormality has resolved. So this case highlights the importance of the usefulness of echo in assessing hemodynamic instability during procedure. This is another thing, another finding which may see during procedure, pericardial effusion. Trace effusion is relatively common in these patients. In these sick patients may have trace effusion. So it is a good practice to do an echo just before TAVR, a transthoracic echo just before TAVR. Because sometimes during procedure, someone will tell that there's an effusion and you will start worrying. Actually, this effusion may be pre-existing. And as you know, subcostal window is more useful for assessing trace effusion than parasternal long axis or apical force chamber view. Suppose there is a large effusion we find, it can be from LV, RV, or from the aortic root. But echo is not useful in assessing the source of effusion. We need to do angiography and see that there is no leak from LV, there is no leak from aortic root. Then it must be from the RV, from the temporary pacemaker related perforation. These are other findings which may find during assessment of instability. You can see an aortic wall hematoma in this patient post balloon dilatation. Or sometimes a balloon expandable valve can rupture the interventricular septum and produce acute ventricular septal rupture with hemodynamic instability. Sometimes the valve may be too deep, which is easily recognizable, producing severe MR as well as mitral stenosis, making the patient unstable. So these are the important assessment during procedure which you can make, especially the implant depth as well as assessment of hemodynamic instability during procedure. Now coming to the post-procedure assessment. Post-procedure assessment are primarily two. One is the assessment of paravalvular leak, and second is assessment of gradient. Gradient is very simple. Look at the gradient. If the mean gradient is less than 10, it is acceptable. If it's more than 10, you need to do something. And you can assess the severity of PVL, mechanism of PVL, as well as management of PVL based on the echocardiographic appearance. How to assess the severity of PVL? With this current generation of valve, the risk of moderate or severe PVL is very less. The current data shows that the risk of moderate and severe PVL is very less, ranging from 0.6 to 3.5% based on the type of valve we use. How to assess the severity of AR? We don't have time to do a very detailed echo, assess the ERO and all. We don't have time. We generally go by the circumferential extent of the leak. If it is less than 10% circumference, it is mild. If it is 10 to 30%, it is moderate. More than 30% is severe leak, which you need to be tackled. We can also assess the severity by angio as well as the hemodynamic AR index. AR index advantage is that it is non-subjective, but the diastolic blood pressure is very important here. And these patients may have low diastolic blood pressure related to anesthetic drugs, blood loss, etc. So this also, even though it is non-subjective, AR index is non-subjective, it also may not exactly assess the severity of AR. So this is already I told, vena contracta and the circumferential extent. Vena contracta less than 3 centimeters is acceptable, 3 to 6 centimeters is 6 millimeters is moderate, and more than 6 millimeters is definitely significant. Something needs to be done for that. You can see this one is a trace AR, which is confined to less than 10% of the circumference in the short axis. Whereas this one, you can see that it is confined to, it started from 12 o'clock to 4 o'clock, which is approximately 30%. So this is a very important quick assessment modality in PVL, and we can decide our plan based on the severity of PVL. And the mechanism of PVL also can be assessed by echo. You know, this valve says half the distance is the only where the leaflet is there. Suppose you put it too deep, it will start leaking from here, whereas it is too high, it will start leaking from here. Too high implant or too low implant. And then there are patient factors like nodular calcification in the annulus where the valve CT will not be perfect. That will also start leaking. So the mechanism of PVL also can be assessed by echocardiography. This patient, you can see there is a calcific nodule here. There is a moderate paravalvular leak. So the treatment is post-dilatation. After post-dilatation, the AR has come down. Whereas this patient got a very high implant, the severe AR. So we need to put one more valve. And this patient is a mixed bag. There's a high implant as well as severe calcification, frame under expansion. So again, the management is balloon dilatation, and after balloon dilatation, the valve has the bicus valve has opened little more, but it is really high. It has come at around -1 or -2 millimeter above the annulus, and there was residual mild leak. Our procedure is not over unless we assess the groin. Please always assess the groin for femoral pseudoaneurysm. This could be the deciding factor in selected patients in outcome. Of course, we can assess the post-procedure value function. We have to assess the mitral valve for MS as well as MR, assess for thrombus anywhere, which may change the management, like giving more heparin or thrombolysis or something like that. So in concluding, echocardiography is important in quick diagnosis of hemodynamic instability during TAVR. It is extremely useful in assessing mechanism of PVL and deciding the management of PVL in these patients. TE guidance is useful in guiding the implant depth in selected patients where intraprocedure TE may be used. Thank you very much for patient hearing.
Thank you, Vijilal, for the wonderful talk, and you stressed on the more of intra procedure, but post procedure also, because nowadays the number of the TAVR has increased. So from the guidelines perspective, you have to before discharge and 1 month and 6 months and 1 year, and many of the time there is an issue that how to look all these things, echocardiography, because the patient may not come to the operator. That will be the other non-invasive echocardiography. So majority of the self-expanding valves are looking like our bioprosthetic valve. So we have to know about the how to see the structural degeneration or thrombus or late complications, because whatever the complication you have said is the immediate one, whatever the injury related to annulus or VSR or mitral valve injury or aorto RV fistulas. But later will be we have to know about the degeneration. So from you have to look for the short axis view, long axis view. So the sometimes may come with a double echogenic layer in the plaques view or dental pattern of the short axis, whether the shape is purely circular, and was already mentioned by Dr. Vijilal about the paraprosthetic irrigation. If it is very less than 10, you can ignore it. For more than 30, you have to be severe. And one thing we have to stress upon is you have to selectively look at the thickness pattern. Many of the time, during initial years, people with a less number, they may oversize it, and it may show the supraannular self-expanding walls. The movement will be less, it will only completely expanded, so the degeneration may expect much earlier. So these are things we have to look in later, just like apart from degeneration, thrombus, and issue related to paraprosthetic regurgitation. And of course, each time other hemodynamic issues, as already mentioned by Vijila, LVOT issues, and just like any other case, valve, PPM also can come in later years. Patient prosthetic mismatch and residual stenosis, and of course, just like others like stenosis and the regurgitation. Shafiq, what's your first?
Hi, Bijilal, excellent talk. Has covered all the points starting from pre-procedural role
of echo. So currently we all rely heavily on CT imaging for planning of TAVR. But echocardiography is just up for the initial diagnosis. But there are certain situations in pre-procedure where we depend on transesophageal echo, 3D echo sizing and all, when we cannot give contrast because of renal issues. So in such patients, when you plan a TAVI, you can utilize your expertise in echocardiogram. Intra-procedure, most of the time, current practice is only when the complication arises, as Dr. Bijala elegantly quoted and demonstrated. In post-procedure echo, as Dr. Ashraf said, it is more important actually to monitor how the valve is behaving over the years. So valve degeneration and thrombus formation, because here you have to keep an extra eye and keep looking at these valve regularly, so that you know how the gradient, the mean gradient is rising over years. So that probably may translate into the long-term durability of the valve. And there are additional structural changes that happen after a successful TAVR, that is regression of the mass, LV mass. So there are indices and there are studies which shows that if there is significant regression, so that it gives a favorable long-term outcome, and how the RV function improves if it was already it was less, and how the left ventricular ejection function improve, how the diastolic function changes. All these are elements which can actually translate into patient well-being after TAVR. Out of these, most of the time, many studies in the early phases have done CT after TAVR to see and define the degeneration of valve, but then it does not come into clinical practice. So we depend actually heavily on echocardiogram, how to follow up these patients and detect early valve failure. Dr. Abhilash?
Abhilash was watching.
Thank you, sir. Thank you, sir. Nice talk, sir. As Ashraf sir already mentioned that actually we are going to do a pre-discharge echo, then 1 month later, 6 months, and after 1 year. Then every year or 6 months, sir? I assume it is every 6 months after that for degeneration. Sir, what's your practice, sir? Sir, how often we want to do the echo? And on follow-up, if we see, say, my moderate AR, what to do with it? If say moderate AS, what to do with it? And when are we going to intervene?
Hello? Can you hear
Yes,
me?
sir. Yes, sir.
Okay. As Dr. Ashraf said, the possibilities are what is something known as leaflet thickening, which results in which is related to thrombus formation on the leaflets. Once you see that and the gradient starts increasing, we like to put these patients on anticoagulation. And the 4D CT is probably the answer in these patients, along with the TE to assess the leaflet thickening, presence of thrombus and all. And if it is demonstrable, then this patient has to be put on oral anticoagulation, preferably warfarin or similar kind of drugs. And you have to closely monitor them and see whether the gradient starts falling into acceptable levels. In my experience, I had 3 or 4 patients where the gradient started rising after 3 to 6 months. A couple of them had a low implant of a self-expanding valve, which makes the supraannular valve actually intraannular, and possibly the leaflet motion becomes restricted, resulting in thrombus formation. And one patient had a severe gradient which remained like that for a year, and then he had a sudden cardiac death. So this is not uncommon. So in our own institutional experience, around 5% of patients had high altitude leaflet thickening and increased gradients. But 2 of them are remaining stable with no further increase in gradients once they are put on anticoagulation. And to share one of my friends' experience, he had initially put these patients on, I think, Apixaban, and but the gradients were remaining high, and after switching to warfarin, the gradients started falling. So these patients will require a high intensity anticoagulation.
So sir will suggest to start on sir.
If there is
Abhilash,
a progressive
only-
increase in gradients and demonstrable leaflet thickening, then it is advisable to start them on anticoagulation with the warfarin.
You have a value, sir, say like a mean gradient of 20 or 25, you want to
Mean
start on
gradient
anticoagulation.
progressive increase in gradients.
Change in gradient.
Change in progress. So normally you recommend dual antiplatelet only, isn't it, sir?
Only dual antiplatelet, but in selected patients like
And how long
small
dual
valves
antiplatelets
and
and
valve in valve procedure, where the neosinus is shallower, there is a higher risk of leaflet thrombosis. So small valves and valve in valve procedure may be a good option to start on anticoagulation, the single antiplatelets early itself.
Basically,
how
the
long
one
you give dual? Sorry.
only issue is whatever we are talking about the patient prosthetic mismatch as is in the other surgical counterpart. We don't know how to see the aortic valve area. There are practical difficulties. For example, the shape of the LVOT may be different, like hourglass, cylindrical. So when you take exactly aortic valve area for the to see the mismatch or stenosis or progressive reduction of the valve area, sometimes practically very difficult in the post-TAVR patient. And now the second point is, and practically very rarely, only echocardiography very helpful. Suppose patient is severely sick and you can't send the patient for CT. And for example, patient on table, the surgeon came to know that there is porcelain aorta and they severely calcified. So then they want to shift to cath lab for the procedure. Then they can do the real echo, and the margin of error is only 10 to 20%. So in a rare scenario, even without CT, as Shafiq said about for calcified patient, you can afford to take in rare situation looking at the echo. In near future, in remote future, we may come with the only echo evaluation and valve sizing with the
It
higher
used to
and
be the practice.
not possible.
10 years,
No,
10 years ago, that used to be the practice. Or
Yeah.
have you done with the
No, when we are coming back
echo guidance, and CT used to be done only in selected patients. So most of the valve sizing was done by echo, but what they found that the risk of the incidence of PVL and severity of PVL is little high in these patients. So it is not that we cannot do procedure without CT.
What I am
It can be
telling,
done.
in a selected patient, the margin of variation will be 10 to 20% if you take echo versus lab.
And you can also limit the volume of contrast by
Yeah.
doing injection in the pulmonary artery, put a catheter in the pulmonary artery and do the angio. Then you need only 30 ml contrast rather than doing IV contrast, which you need to be 60 to 70 ml to get good visibility. You can put a pectoral catheter in the pulmonary artery and do angiogram. That way also you can reduce the contrast of patients with a significant renal dysfunction.
So
yes, sir.
with this,
Sir, one question, sir. One final question. Sir, many of these patients are elderly. So how long you really recommend to continue dual antiplatelet, and when can they be switched over to single antiplatelet if at all?
After one, the recommendation says I think 6 months to 1 year DAPT, and after 1 year it is single antiplatelets.
Yeah. Thank you, sir.
Shafiq, any other? Nothing. So with the very very good speech, and we learned a lot from practically and theoretically from all of the speaker and also my co-chairpersons, Dr. Shafiq and Dr. Abhilash. Thank you all, and we can conclude the session within expected time. And no other comments, Shafiq, any other comment, Abhilash? And
No, nothing, sir. Thank you.
Nothing.
That was a nice talk, nice discussion.
Thank you, Dr. Ashraf, Dr. Abhilash, and
Thank you, sir.
Thank you very much.
And
Thank you, sir.
And
Thanks
handing
to the
over to
organizers.
I think it was bang on time. We had a great talk by Dr. Bijilal, and I thank Dr. Bijilal for a very concise talk with wonderful slides. And I thank all the chairpersons, Dr. Ashraf, Dr. Shafiq, and Dr. Abhilash for giving valuable insights. Thank you so much.
Thanks. Thanks.
So I think with this we can move to the next session. We got the prestigious IAE award session. We have got 6 cases for the award session, and we got three giants as the judges. We got Ramakrishna Pilla sir, we got Koshi sir, and Jabir sir. So I welcome the chairpersons or judges for the award session. Koshi sir.
Pilla sir has joined. Has Pilla sir joined? Jabir? Dr. Jabir, have you joined?
Sir, I'm here. I'm here, sir.
Pilla sir has joined?
I will see Pilla, sir.
Can we start, sir?
Yeah, of course. Let us start.
Pilla sir,
Sir,
please.
we can start. We can start.
Pilla sir, please start.
So shall we go ahead with the first case, sir?
Yes.
So I think the first case we got aorta to LA fistula after aortic valve replacement. I think it is presented from Government Medical College, Calicut, and the presenter is Dr. Achyutananda Govindan.
Good evening, Chair, colleagues and audience. I thank the organizing committee for giving me this opportunity to present a case of aorta to LA fistula after aortic valve replacement. This is a case of a 66-year-old male who presented with NYHA class 3 symptoms. He had undergone a double valve replacement in 2013 for rheumatic heart disease with a severe AS and moderate MS and MR. He had a double TTK Chitra valve in both the lesions. On examination, the patient had features of atrial fibrillation with elevated JVP with mild cardiomegaly. Both the first and second heart zones were metallic with an PSM at apex and ESM at left second and third intercostal space. And in the chest X-ray, the lung fields were clear and the patient had the mild cardiomegaly. There is double density sign and ECG was suggestive of atrial fibrillation with LVH. We first proceeded with transthoracic echocardiography. You can notice that the LV function has a okayish function, and there are no significant leaks or any valvular dysfunction of the prosthetic valve. There is no new onset disease of the tricuspid valve. But then this was not correlating with the clinical findings, and since there was discrepancy in the transthoracic echocardiography and the clinical examination, we proceeded with transesophageal echocardiography. Multiple views were taken, and you can notice that in mid-esophageal aortic valve, when it was seen in short axis and long axis, a shunt is happening between the aortic valve and the left atrium, in close proximity to the anterior mitral leaflet. So we have a diagnosis of aorta to LA fistula, and otherwise the prosthetic valve function was good. No other additional lesions or masses were noted, and so we discussed with the patient and we proceeded with device closure with the CVTS team in backup. The pigtail was parked in the aortic root and an injection was taken, and you can see the LA filling up, following which we passed an MPA, 5 French MPA across the lesion, and then we went into the left atrium. 6612 ADO2 device was deployed across the lesion, and then the final injection was taken. The final angio was taken, and we can notice that it does not protrude into the prosthetic valves. Of course, we cannot we cannot view the prosthetic leaflets because it is TTK Chitra valve. Post procedure, we took the patient for transesophageal, I'm sorry for the typographic error, transesophageal echocardiography, we can notice that there is no residual shunt across the lesion, and the device is in situ, and it is not impairing the prosthetic valve function. In the meantime, the patient's symptoms also improved, and he was otherwise asymptomatic. Speaking about iotoatrial fistula, it is a very rare lesion, and even rare is congenital presentation of iotoatrial fistula. It does occur as a complication of infective endocarditis, aortic dissection, aortic aneurysms, ruptured sinus of Valsalva, or any trauma, and surgeries of any of these conditions. And in cases such as in CABG or percutaneous ASD device closures, it happens. Rarely, it does happen with Kawasaki disease or Takayasu arthritis, and sometimes even in giant cell arthritis. It can range from asymptomatic presentation with incidental murmur to heart failure. It can be single, and at times it can be multiple. There is usually a murmur, but then it is non-specific and it does not correlate with the size or severity of the lesion. One attempt transesophageal echo in cases when transthoracic is inconclusive, depending upon clinical assessment, which is clearly noticed in this patient. One can proceed with surgery or percutaneous closure, depending on the patient consent and the expertise of the operator. High quality images with less attenuation can be produced in transesophageal echocardiography. And when the aorta to LA fistulas are posterior to aorta, it is better delineated, and the turbulent flow of the fistula is mistaken on transthoracic echocardiography, especially if it is close to the prosthetic valve and it is considered as a prosthetic valve malfunction, and the treatment is taken in a different direction. It helps in assessment of the size, location, and the number of fistulae, and thereby it helps us in planning the management. Interchamber communications and fistulous tracts that are particularly small are best tracked by multiplanar transesophageal echocardiography. We couldn't attempt, we did attempt a transesophageal echocardiography, but then the images were not clear. Coexistent complications such as annular abscess, extension into upper interventricular septum, or the subaortic area, and pseudoaneurysm formation can also be assessed using transesophageal echocardiography. Aorta to LA fistula can be closed with ADO 2 device with the fluoro and along with the transthoracic or transesophageal echocardiography. Here, we couldn't use transesophageal echocardiography during the procedure simply because of logistic issues. And we can assess the patient in follow-up for looking at the location of the device for prolapse, dislocation, and for residual lesion. Thank you.
See, this patient had a communication between aorta and LA and had only a systolic murmur. Is it very common? Because there is a gradient both during systole and diastole. Can you hear? Am I audible?
You are audible, sir. Dr. Achudanand, can you hear, sir?
Please unmute yourself, Dr. Achudanand.
Dr. Achudanand, we can't hear you. But yeah, he's also not seen also now.
Am I audible?
You are audible but breaking. Your voice is breaking.
Yeah, actually, multiple. Sir, am I audible?
You are audible,
Hello?
but your
Go
voice is
Go ahead.
breaking.
Hello.
Anyway, you go ahead.
We are
There are like multiple case studies have been shown that with a similar situation, there are patients who are presented with an ejection systolic murmur, a pan-systolic murmur, and sometimes continuous murmur as well.
So murmur is not
But
very
then it has been shown
reliable.
that yes, sir, it is not reliable.
Okay.
Multiple
See,
murmurs
what
have been
is the
there.
reason for this fistula? See, because after the aortic valve replacement, if the sutures give way, you get a paravalvular leak and you get aortic regurgitation. No, if you have to have a communication between aorta and LA, there has to be an aortic injury. You sit, what was the location? How much above the annulus was this? And second point, you did it without a TE, you know. And this is a Srijitra valve, TTK valve, in which the disc is actually not visible radiologically. So, do you get an idea where exactly is the leaflet and how to deploy the device and all that?
Sir, actually, there were some logistic issues with the planning T in this patient. There are some institutional policy issues. That was the reason we couldn't arrange for a TE during the procedure. Although we had a as a
Achudanand, here there was a difficulty. Here there was a difficulty assessing the
during the procedures.
We are not able
and
to
regarding the mechanism of the fistula. Yes, sir. Yes, sir. There was a difficulty in assist.
Am I audible?
You are audible, sir. You are very loud and clear.
You are very well audible.
The operation was given in 2013, 10 years back. And you know at what point this fistula developed? What is the likely cause?
Yeah, yes, sir. I'm audible. Am I audible, sir?
Yes.
Now you are better. Yeah, you are audible better.
Yes.
See, you switch off your video. Audio will improve.
We are not clearly sure about that, sir. But then the patient had progressive. We are not taking.
Sir, I think there is some problem with his bandwidth. It's extremely difficult to hear. Shall we go to the next candidate then?
I think so. Anyway, very interesting case.
Very interesting case.
I think we will go to the next one. Can we go to the next one? Sir,
am I audible now? Can I?
Yes.
Good evening, everyone. I'm Dr. Tajfir, Senior Resident Cardiology, Department of Cardiology, Government Medical College, Kannur. And I'm going to present post myocardial infarction VSR device residual leak reintervention. And coming to history, my patient is 55-year-old male patient, non-case of diabetic and hypertensive. Patient presented with inferior wall MI and the coronary angiogram had shown double vessel disease. Patient underwent primary PTCA to RCA outside the center. And patient admitted our institution with pulmonary edema. And echo had done, it has shown 8 mm basal VSR with moderate left ventricular dysfunction. And we decided to take the patient for VSR closure. VSR closure done through femoral route, and 16 mm muscular device had used here. You can in LA view you can clearly see the muscular device, and there is a very minimal residual shunt also. And on echo in short axis view, you can clearly see the vascular device, and along with very trivial VSR leak. And here you can see the basal segment. There is mild aneurysmal basal segment, and so patient discharged from our hospital, and post-procedure follow-up, there was an initial improvement, and left ventricular ejection fraction became 40%. At 3 months, Patient readmitted with severe anemia, a hemoglobin of 6.6 gram percentage. There was a generalized edema and hemoglobinuria, and LDH was 1200. And this feature suggestive of hemolytic anemia. And we treated the patient with 2 pints of blood transfusion, and we decided to go for re-intervention. So we started with a multi-purpose diagnostic catheter with a straight thermowire. The course was serpiginous and it was very difficult. And we made a AV loop here, and patient treated with a 10 mm vascular plug. You can clearly see the vascular plug here. And on next shot, you can see the device and the plug. So the leak has stopped here. And on echo in short axis view, you can see the muscular device here at 11 o'clock position, and there is a plug here in the 12 to 1 o'clock position. On follow-up, patient left ventricular ejection fraction is improved, and clinically also patient improved very much, and there was no residual leak, and hemoglobin also improved. It's 10 gram. There was no further hemolysis. And coming to the conclusion, the basal BSR is very difficult to treat both surgically and percutaneously. Hemoglobinuria due to residual VSR leak is extremely challenging with its serpiginous route, that too with basal location. Ambulance vascular plug could successfully treat hemoglobinuria, which is unique procedure in literature. Thank you.
First of all, congratulations for managing a basal VSR, which is very difficult to treat. But after keeping that muscular device, there was a significant shunt even at that time, which progressively worsened. So do you think upsizing the device at that point of time would have helped? I'm just asking in retrospect.
It may regress.
It's difficult. It's an acute MI. So bailing out is the important point. We agree with you.
We were expecting that
it will come down.
It will come down because the device may expand more.
Residual leaks with implanted devices can lead to severe hemolytic anemia and hemolytic jaundice. So it was very good that you could close it with the device, with the ambulance plug.
Okay.
Did you think of using, doing it under conscious sedation or with TE guidance?
The conscious sedation.
Anesthesia and TE guidance would have helped, or we could do it, we could manage it anyway.
Yes, sir.
This is ABP 2-3, which one?
Sir,
what is the distance? What is the length?
Sir,
because the septal thickness will be something like, say, 6 or 7 millimeter in this patient, or maybe 8 millimeter.
Yes, sir. 10 mm, sir.
Anyway, it is a very good result and very nicely managed. Dr. Jabir, any question? So can we go to the next case?
Yeah, I think we can. Yes.
Okay. Thank you.
Thank you.
Thank you very much. Exciting case.
Respected professors and friends, I am going to present a case titled Once Invited Must Be Honored. I am Dr. Lakshmipriya SV, third year VM Cardiology resident, Government Medical College, Trivandrum. My case is a story of a patient, 55-year-old female, who had a history of rheumatic heart disease, mitral stenosis, and mitral regurgitation, for which mitral valve replacement with ATS Medtronic valve was done in 2017, which is a bileaflet valve, and she was on acetylene 2 mg with history of intermittent drug default. She presented with dyspnea and orthopnea of 4 days duration to our OPD with no history of fever or history suggestive of any embolic events. And on examination, she was conscious and oriented and tachypneic with a pulse rate of 78 per minute regular, BP of 150 over 90 millimeters of mercury measured in right upper arm in supine position, respiratory rate of 30 per minute regular. CVS examination showed JVP elevated 8 cm above the sternal angle. S1 was metallic and dull. A2P2 was heard with loud P2 and normal split. Mitral metallic opening sound was not heard with no S3, S4 or murmur. Transthoracic echocardiography showed restricted mobility of the prosthetic valve leaflet with mean gradient of 19 millimeters of mercury with no definite thrombus. And prosthetic valve thrombosis was considered as the patient had acute onset and short duration of symptoms and a history of drug default and inadequate anticoagulation, and restricted mobility of prosthetic valve leaflet with increased gradient of 19 millimeters of mercury. She was treated with injection streptokinase, 5 lakh IV bolus, followed by 1 lakh unit per hour infusion, followed by heparin infusion at a rate of 1000 units per hour for 24 hours. Post 24 hours, the echocardiography was repeated, which showed improved mobility of the leaflets and improvement of gradient from 19 millimeters of mercury to 5.72 millimeters of mercury. She got symptomatically better and she was discharged with 3 mg of acetylene after optimization of INR. And she was discharged after discussing with the patient about frequent follow-up. And again, immediately she presented with history of oral bleeding to medicine casualty and was admitted, and acetylene was discontinued for 2 days and was restarted at a dose of 1 mg per day. And again, she had a period of inadequate anticoagulation. And within 2 months of the first event of prosthetic valve thrombosis, she presented again with dyspnea on exertion functional class 2. And she was conscious oriented with pulse rate of 70 per minute regular, BP of 130 over 80 millimeters of mercury, respiratory rate of 14 per minute regular, JVP was not elevated, S1 was metallic, A2P2 was normal, no S3, S4 or murmur, and her INR value was 1.2. And her ECG showed sinus rhythm at a ventricular rate of 100 per minute, P left atrial abnormality, PR interval of 0.16 second, QRS of 0.06 second, QRS axis of plus 45 degree, and normal R wave progression. Transthoracic echocardiography was done, which showed restricted mobility of the prosthetic valve leaflet with a gradient of 15 millimeters of mercury. And this is the picture depicting continuous wave Doppler with mean gradient of 15 millimeters of mercury. And transesophageal echocardiography was done, which showed restricted mobility of leaflet with increased gradient and mild paravalvular leak. And this is the video showing, the left one is our patient's image showing restricted mobility of leaflet, and the right one showing normal mobility in a normal patient, how a prosthetic valve moves, opens and closes is the right image, right video. And fluoroscopy was done, which showed impaired closing, restricted mobility, and a closing angle and an opening angle which is normally around 18 degrees, but for our patient it was 65 degrees. And considering prosthetic valve thrombosis, again we advised redo surgery with bioprosthetic valve, but as she was not willing, planned for tenecteplase lysis after joint discussion, and tenecteplase intravenous bolus of 35 mg was given, and she had rapid response with improvement of gradient to 5 millimeters of mercury and improved mobility of valve leaflets. On the first day, patient was completely normal, and on the second day, patient had behavioral abnormalities and CT head was done, which showed frontal hematoma, and we were forced to stop all the anticoagulant medications. And on the 5th day, she again developed prosthetic valve thrombosis, acute pulmonary edema, and she succumbed to death. And this is the story of our patient. Thank you.
Thank you, Dr. Lakshmi. It's a sad story because recurrent thrombosis, and it's not a patient's fault, but it just happened like that. So the first instance when you decided on changing to bioprosthetic, well, I think that was a correct decision, but unfortunately the patient couldn't agree for that. How did echocardiogram help you in this case? Was the diagnosis complete with a transthoracic echocardiogram? Was there a need for a transesophageal echocardiogram? Any additional thing that was provided by the transesophageal echocardiogram? Because your diagnosis was basically with an increased gradient. The gradient increased to 15 millimeters of mercury in the first instance, isn't it? That was transthoracic echocardiogram. Am I right? We can't hear you, Dr. Lakshmi.
Lakshmi, you are muted.
Lakshmi, you are not audible to us.
Are you muted? Not yet.
She's not muted. I think some connectivity issue. She was very loud and clear so far.
No, that's a recorded one. And this is
recorded
real
one,
time.
sir.
Oh, this is.
That is why you find a discordance.
All right. Oh, this is
Lakshmi,
live
try
and the
avoid
other
using
one
that
is
headphone. Try avoid using that headphone.
Lakshmi, please verify your connections.
And I wanted to ask you another thing. See, this van was implanted in 2017 and the thrombus occurred in after 5 years. And I don't think she was very much compliant with treatment all along. Then after 5 years, developing, thrombosis and then again developing an issue. Any pathotic state in addition to the discontinuation of she would have discontinued treatment in between also, people like this.
But
and second point, was she on an antiplatelet? You did not mention anything about aspirin. Because a mitral valve replacement patient should be on aspirin as well.
As well, yes.
Especially a patient like this, and you should aim for a higher INR. And then, she had bleeding, which is again, anyway, you're not able to answer, due to some technical problem.
The title was rather cryptic and interesting. I wonder
Pardon, sir?
The title, invited, when invited, invitation should be honored.
Very cryptic and very interesting. And I guess the invited guest is mitral valve.
Anyway, good that you gave
Lakshmi is audible now, sir.
But I think it gives a clear message, sir. When the patient, as Koshi sir said, she unlikely to be compliant to the oral anticoagulation. But when the oral anticoagulation, there is a problem, thrombosis, and we cannot manage the patient with oral anticoagulation, a bioprosthetic, change over to a bioprosthetic valve is the first thing that can be done and the most effective thing. Had she agreed for that thing, I think we would have been able to save her life. What do you think?
Exactly. And the likelihood of thrombosis is higher during the initial years. As time elapses, the likelihood of thrombosis comes down. So developing after 5 years in a patient who was erratic with anticoagulation is a bit unusual, that is all. We are not able to connect, Lakshmi, we are very sorry. We will have to leave you.
Lakshmi, it was a good case, a very, very of great practical implication.
Okay.
I thought.
About one point about this bolus dose of tenecteplase. Bolus dose of tenecteplase.
Yes, sir.
Now, both altiplase and tenecteplase can be given as slow, very slow, ultra slow infusions. This has happened in the last 2-3 years. And after the altiplase paper came, it is considered even superior to surgery.
And even sir, the data with tenecteplase is not that great in prosthetic valve thrombosis. Most of the data and the recommendation is for alteplase or the old one, streptokinase.
And I think in this patient, the thrombus is not very huge.
Yeah.
Because the issue related to thrombolysis is actually embolization.
Yes.
That is why people tell that if the thrombus is very huge, you go for a surgical treatment. That is why that is a stronger indication compared to thrombolysis when it comes to the prosthetic valve.
The current recommendation for prosthetic valve thrombosis, they give the class 1 indication for redo surgery.
Exactly.
Rather than for thrombolysis.
Exactly. If we knew this, this patient should have been given a bioprosthetic valve. And patient is in sinus rhythm or AF?
Sinus rhythm, she was telling about the PR interval and all.
Exactly. So all the more reason to be on a bioprosthetic valve. Anyway, good. Good presentation. Sorry, Lakshmi, we cannot connect. Okay. We will go to the next one.
Very good evening to one and all. I'm going to discuss about 3D echocardiogram pictures in a case of ruptured sinus of valsalva aneurysm. Our patient is a 70-year-old female who presented.
For the candidate to talk, they have to be on faculty link, not delegate link.
No, they have been given faculty link.
Yes, madam, all are in the faculty link. I think
Without
it's their
faculty
connection
link,
issue
madam,
at
they
their
cannot
end.
enter this.
Yeah,
Dr.
connection
Praveen, can you
issues at
check
there.
whether there is any logistic issue?
No, sir.
No,
Without
sir.
faculty link, she cannot come on this podium.
It is a connection problem at their end, sir, because we can hear the discussion.
Okay, anyway, we can't do anything about it. Okay.
Praveen, we can go ahead with the other.
Yes, sir.
Okay,
Yes, sir.
okay, we will go to the next one.
Very good evening to one and all. I'm going to discuss about 3D echocardiogram pictures in a case of ruptured sinus of valsalva aneurysm. Our patient is a 70-year-old female who presented with an acute presentation of chest pain, dyspnea, and palpitation for 3 days. On examination, her pulse rate was 90 and her blood pressure was 130/60. Her JVP was elevated with a CV wave, and she had a continuous murmur in the tricuspid area. This is the 2D transthoracic echocardiogram in the parasternal long axis view. We can see that the chamber sizes are normal, mitral valve is normal, and there is a mild aortic regurgitation. And this is the apical four-chamber view, which shows turbulence in the right atrium due to tricuspid regurgitation. And if we observe closely, the turbulence also seems to persist during the diastole. And when we open the aortic root in the apical five-chamber view, we can clearly see the turbulence gets arising from the right coronary sinus of the aortic root and confirming the presence of a defect between the aortic root and the right atrium, confirming RSOV. And an interesting feature in this echo is the right coronary cusp of the aortic root is getting pulled towards the defect with some kind of a suction effect due to the RSOV, which may explain the reason why there is mild aortic regurgitation. This aortic regurgitation is usually an accompanying feature in case of RSOV. So to further delineate the shape and size of the defect, we did a transesophageal echocardiogram. This is the mid-esophageal view of the aortic valve, short axis view, showing the turbulence between the right coronary sinus to the right atrium, and the RSOV is confirmed in this, which opens very close to the tricuspid valve in the right atrium. This is the long axis view showing the defect, and in 2D transesophageal echocardiogram, we measured the defect to be 4.27 millimeters. So we did the 3D transesophageal echo to further delineate the shape of the defect. Since we didn't find any windsock in the 2D echocardiogram, we proceeded with 3D. And what we saw here is some kind of a linear defect in the right coronary sinus with the width of around 4.2 millimeters and length was greater than that. This is a color Doppler in 3D showing the turbulence across the defect and mild aortic regurgitation. So this 3D, I am rotating around x-axis and y-axis to clearly show the defect, and I'm measuring in the defect in 3D TE. So the width of the defect was smaller and the length was larger, which explains the linear nature of the defect. So the size of the defect came to be width 4.5 millimeters and length of about 11.5 millimeters. So this is a still image showing the size of the defect, 11 into 4.5 millimeters. So the size came to be larger than what we measured in 2D transesophageal echocardiogram. So because we can never cut in this particular plane, cutting across the length of the defect, all the 2D images we got by cutting across the width of the defect. So we would have missed the actual size of the defect if we went ahead based on the 2D images. So we decided to do transcatheter intervention, and this is a CAT study done before that, confirming the presence of sinus of Valsalva with a very small windsock. The defect we can see clearly from the right coronary sinus into the right atrium, just near the tricuspid valve. So this is the illustration of our patient's defect from the right coronary sinus to the right atrium. So we went ahead with transcatheter device closure of the defect using the AB loop method for introducing the sheath. We delivered a PDA duct occluder of size about 10 into 8 millimeter. So we selected a size higher than the width but lower than the linear dimension. So we expected the device to conform to cover the entire defect. So this is the post-procedure images, 2D transesophageal echocardiogram, showing the device sitting nicely across the defect and there is no residual shunt. But aortic regurgitation is very minimal, even though the device appeared to be close to the right coronary cusp of the aortic valve. The AR is negligible and we accepted this result. So this is a 3D transesophageal echocardiogram post-procedure. We can see the defect being nicely closed by the device. And this, I am cropping the 3D images to show the device, how it is close to the aortic valve. This is the color Doppler showing there is no residual defect and there is trivial mild AR which was not higher than the pre-procedure. This is a short axis 3D transesophageal echocardiogram. Here you can see the non-coronary cusp. This is the left coronary cusp. And this one is the right coronary cusp, and you can see the defect here, device here closing the defect, and the still images clearly shows the device. Usually RSOB can be closed with PDA occluders, that is small waist double disc occluders. Both the aneurysmal and window-like RSOB can be closed by these occluders. The tubular occluders can be closed by muscular VSD occluders. So this case I presented because in our case 3D transesophageal echocardiogram represented an adjunctive tool to demonstrate exactly the size and shape of the RSOB, and it helped us in selecting the device size accurately and helped in achieving a successful device closure. So thank you one and all for patient listening.
Thank you. Thank you, Dr. Rangasamy. It was a beautiful demonstration of the application of 3D transesophageal echocardiography in certain situations where you are not getting the adequate information from the transthoracic or pure transesophageal echocardiogram. Your 2D, it was not clear because you could see a continuous flow just beneath the tricuspid leaflet, but as you also pointed out, the windsock cannot be clearly delineated. Even a simple transesophageal echocardiogram also could not demonstrate, but at the same time, all the details that is required for how to close, what device should be used, what the measurements, what are the measurements required for the device, all these things are clearly delineated from the 3D transesophageal echocardiography. And do you think this 3D transesophageal echocardiography is mandatory in all RSOVs before closure? Because you get all the information that can be given in as accurate as a CT angiography.
Sir, I don't think it is mandatory. So first of all, I feel the patient has to be stable enough to do the 3D transesophageal echocardiography. Otherwise, CT angiogram will be another option, which will also give the same details. This patient, after we did the 3D TE, we thought that CT additional irradiation with CT angiogram may not be required. We got all the information. So we thought we will go ahead with the device closure.
Because most of the RSOVs, unless they are in acute heart failure, a transesophageal echocardiogram is usually possible. We do transesophageal echocardiogram even in acute aortic dissection. So transesophageal echocardiogram, mostly 95% of the cases it is possible. The patient will be stable for that thing. Wonderful job, great case. And I'm so happy to see all the echo descriptions. This is really, you concentrated on the echo rather than on the procedure.
Thank you, sir. Thank you very much.
And by your 3D, the length is actually around 11 millimeter. That came
Yes,
as a
sir.
surprise because
Yes,
by the 2D measurement, It appeared to be very small and something like 4 millimeter. Now you could delineate it very clearly, 11 into 4.5 or something like that. What was the size of your device?
Sir, 10 bar 8, sir. It's an ADO.
Was it ADO 1 or ADO 2?
ADO 1 only, sir.
ADO 1 was. Okay.
And coach sir, when we look at the angiography, it was clearly delineated. The length, it is a long thing. The long stalk can be well delineated in the angiogram, and it's almost replica of the 3D transesophageal echocardiogram.
Exactly. I think all the
Not seen
required
in the
information
transthoracic
you
or
got.
the it's a simple transesophageal echocardiogram.
Yeah, the windsock was very well seen in the angiogram.
Yeah, very well seen in the angiogram.
Pictures that were the echo pictures shown here were magnificent. It is almost looking at an anatomic specimen.
Exactly.
Thank you, sir. That's what we felt. 3D was very much helpful in our case, sir.
Yes, yes. We are greatly impressed by the quality of the 3D pictures.
And in fact, I think we are underutilizing this technique or utility of 3D transistor
imaging.
3D imaging.
Okay. Can we thank you very much? Thank you.
Thank you, sir. Thank you.
You are from Madurai, no?
Yes, sir. I'm from Madurai.
So thank you for coming for the Kerala IAE conference.
I'm also very extremely honored and privileged to be here, sir, presenting.
So thank you very much and our regards.
Thank you, sir. Thank you.
Okay. We'll go to the next one.
Yes, sir.
Good evening, everybody. I'm Dr. Suhas Alur from Calicut Medical College. Here we present to you a 52-year-old female who has come to us with worsening heart failure and unintentional weight loss for the past 6 months. She has significant past history that she underwent a mitral valve replacement with a 26 mm TTK Chitra valve in 2010 for rheumatic heart disease with severely calcified mitral stenosis. 5 years she was asymptomatic, and after that she noticed class 2 dyspnea, for which she was evaluated and found to have an LV to RA shunt. However, at that point, she was not willing for any further procedure. Now she has come with worsening symptoms. On evaluation, she was found to have cardiomegaly, prosthetic heart sounds were sharp, a loud P2, and a pansystolic murmur of 4/6 intensity at left lower sternal border. X-ray showed cardiomegaly with right atrial enlarged. We subjected her to transthoracic echocardiography, which revealed a dilated left atrium, a dilated right atrium, and eccentrically directed systolic jet into the right atrium. On modified short axis here, you can see that the jet, in fact, is arising from the left ventricle and going into the right atrium. In fact, getting us to a diagnosis of LV to RA shunt, or the so-called Gerbeau defect. We subjected her to transesophageal echo, where you can see that the mitral valve processes is moving very well, and the gradients across mitral valve is also normal. Here you can very clearly see the LV to RA shunt. In fact, there are two shunts, one being larger than the other. Further, going into the 3D TEE, you can see that there is defect in the membranous septum area, and in fact, a color interrogation also shows the direction of flow from LV to RA of this 3D reconstruction. This is another 3D image showing the jet filling into the right atrium. Now, here we have a patient who is in florid heart failure, emaciated, and is deemed unfit for general anesthesia. So we have to take her up for a procedure. However, intra-procedure TEE is impossible, and we do not have intracardiac echocardiography in our center. So with this, we had in front of a challenge, and we took up this patient for a fluoroscopy and transthoracic assisted shunt closure. Here you can see that the LV angio is demonstrating the shunt from LV to RA and a dilated right atrium. Cath revealed a QP by QS of 2.4 and an RVSP of 65 millimeters mercury. We went ahead and deployed an ADO2 6/4 12 mm configuration after creating an AV loop from the venous side, after confirming the position with multiple angios in fluoroscopy as well as transthoracic echocardiography. This was post-deployment transthoracic echo showing the device in situ, and in fact there is only a minimal residual shunt across the device. This is transesophageal echo, where you can see the so-called device, as well as there is only a minimal residual shunt across the device. This is the short axis. You can see the better profile of the device and only a minimum tricuspid regurgitation, which was present even earlier. There was the mitral valve prosthesis was functioning normally and the gradients were normal, and there was no LVOT obstruction as well. So here we present to you a case of an acquired LV to RA shunt post mitral valve replacement, which was diagnosed 5 years after surgery. This defect was demonstrated by transthoracic echo and was better defined by transesophageal imaging. We closed it with a fluoroscopic and only transthoracic echo guidance with an ADO2 device. Right from the early 20th century, people have shown interest in LV to RA shunt, and 1958, Gerbaud, after 5 surgeries of similar condition, was called as Gerbaud defect. With present times, with increased interventions and better transesophageal and transthoracic echo modalities, more and more cases are being diagnosed. Here we have type 1 and type 2, where is direct and indirect, and the type 3 is the combination of the two. Now looking into acquired causes of LV to RA shunt, half of them are iatrogenic, amongst which majority are again post-valve replacement, majority after aortic valve rather than mitral valve, after some congenital heart disease like TOF, followed by ASD and VSD device closures. Infective endocarditis, especially complicated with aortic abscess, and blunt trauma to the chest can also lead to LV to RA shunt. In a 2015 systematic review, more than 70 cases of post-valve replacement have been described of LV to RA shunt, and since then, more than 25 cases have been published. Very recently, an interesting case of LV to RA shunt post-TAVR has also come to light. In fact, it's a diagnostic challenge since it's a very low incidence and it is very easily confused with a more commoner systolic jet into the RA, that is tricuspid regurgitation. Presence of prostheses and their artifacts adds on to the challenge. The high velocity jet into RA, in the absence of telltale evidence of severe PAH, that is eccentricity index or RV free wall hypertrophy, in a given clinical setting should in fact raise the suspicion of this particular entity. Transesophageal echo has a good sensitivity and specificity over transthoracic, and MRI adds on to the value of velocities as well. Heart failure and associated infection makes it very clear to close this defect. However, the small shunts, there is conflicted opinion. Now looking into the management aspect, its majority of them are closed by surgery, and however, increasingly percutaneous interventions are increasing with the recent times with imaging modalities as well as increased intervention skills of the operators. So to conclude, here we present a case of LV to RA shunt after MVR, which is an extremely rare complication. It can be safely closed with an ADO2 device, even in extremely sick patients who are unfit for general anesthesia with fluoro and TTE guidance only. A high velocity eccentric jet into RA, which is disproportionate to PAH, and a clinical suspicion in a particular case should have high suspicion for this particular entity, that is the LV to RA shunt or a so-called Gerbaud defect. Thank you so much.
Thank you very much. I think a very nice case and very well managed. See, what could be the mechanism of this shunt developing between the LV and RA? Because there has to be some damage to the AV septum, during the mitral valve replacement.
Yes. Sir, the risk factors which have been enumerated are usually the heavily calcified mitral valve.
Was it a calcified valve?
Yes, sir. Yes, sir. It was a very heavily calcified. The surgical notes suggest that it was a very calcified aortic valve. And along with that, tricuspid annuloplasty, if at all with MVR is done, it adds to the risk of developing this particular entity.
So there has to be some damage to that AV septum. Otherwise, they cannot develop an LV RA shunt. Because this patient did not have any paravalvular leak.
No, sir.
So it is not the sutures giving way.
No, sir.
I think it is similar to the case which was presented today, a patient developing the communication between aorta and LA. It's similarly, between LV and RA. It has to be a trauma during surgery, which a small thing which subsequently, because of the hemodynamic stress, getting enlarged.
Yes, sir. The
anyway, it was diagnosed and properly treated. Very good.
His echocardiographic pictures were also exceptionally good. Well, that he could delineate the anatomy very well with this thing. Can you do the procedure under TE guidance?
TE guidance would be better to better delineate the size of the defect and also placing and see whether the discs have held on to the defect, and it would be an added advantage, definitely. However, we had this issue of not, she was very sick and her BMI was in fact 15, and we thought we will go ahead with the backup of general anesthesia and try to do it with, and her transthoracic echo windows were fortunately good. So we kept looking at them and also taking orthogonal angios before deploying the device.
Oh, you did it under a, what do you call a limited anesthesia?
Yes, sir. Conscious sedation with a backup.
What was the distance between the mitral annulus and the tricuspid annulus?
Mitral annulus and the tricuspid annulus. We did not particularly look into that. I'm not aware at this point.
Sir, you want to ask something?
Yeah.
Ramashan sir, any comment?
No, I was thinking about the hemodynamics would have been quite interesting in this patient. You see something like a tricuspid regurgitation, and the gradient is much more than you would expect normally with the PAH. And without other manifestations of PAH, like RV, PA,
yes, sir.
Suggesting severe PAH. That would be
an uncommon reason for step up in the RA.
Yes.
Uncommon, yes, sir.
Yeah, one of the
probably the least common.
The list contains a few.
And unusual cause for a prominent V wave in the JVP. Not V wave, a systolic wave in the JVP.
Systolic wave. And these are situations when the diagnosis is not clear. Another imaging modality like a CT angiography or a cardiac MR may help.
Yes.
Nice case, very well done.
Thank you, sir.
Good pictures.
Thank you,
sir. So I think we'll go to the last case, and I think we are on time. Exactly on time.
Perfect.
6:50. Okay.
Perfect timing.
So last case.
Good evening, respected teachers. I am Dr. Nilanjan, a final year DM trainee from the Department of Cardiology, Medical College, Thiruvananthapuram. I am going to present today a tale of a broken heart. It was a 79-year-old gentleman with type 2 diabetes, hypertension, chronic kidney disease, reformed smoker, and COPD. He presented with a central chest discomfort along with sudden onset dyspnea and fatigue in functional class 4, developing within a span of 24 hours while at rest at home. In MCH casualty, he was found to be hemodynamically stable. Pulse rate was 78 per minute, regular normal volume, and peripheral pulses were bilaterally symmetrical. Blood pressure was 130 by 92 mm mercury in both the upper arms, and clinical findings of all 4 systems were normal. His initial ECG revealed he was in sinus rhythm. Pulse rate was 79 per minute. P was normal. PR interval 120 milliseconds. QRS was of 100 milliseconds. QRS axis minus 45 degrees. There was no ST elevation. However, ST depression with T wave inversion was noted in lead 1, AVL, V5 and V6. Poor R wave progression across the precordial lead was noted. And upright T was noted in B1. IVCT was noted in B3 and B4. We then did a transthoracic echo, and the findings were quite interesting. I'm going to present here only the relevant images. In peristernal long axis view, we found the LV, RV, and the LA. LV seemed to be contracting well, and behind the LV, we noted pericardial effusion. That was not the only finding here. We also noted 2 deficits in the posterior wall of the LV and bidirectional flow of blood between the LV and this pericardial effusion. That means we were most probably dealing with a case of LV pseudoaneurysm. In peristernal short axis window, we noted no regional wall motion abnormality in the LV. LV size was normal, and LV ejection fraction was 58%. Pulse wave Doppler across the pulmonary valve revealed acceleration time 96 milliseconds. That means the patient was likely to be having pulmonary hypertension. In apical 4-chamber window, we noted the LV, LA, RV, and RA. LV seemed to be contracting well, and behind the left ventricle, posterolateral aspect of the left ventricle, we noted this pericardial effusion. We also noted two deficits along the posterolateral wall of the LV and bidirectional flow of blood through these deficits. We measured the size of those deficits, and they were of 0.8 centimeter and 0.6 centimeter. And in peristernal short axis window, we noted the bidirectional flow of blood between the LV cavity and the pseudoaneurysmal sac again. We also noted that the patient was having moderate MR and mild to moderate tricuspid regurgitation. Tricuspid regurgitation max PG was 50 millimeter of mercury. We measured the size of the pseudoaneurysmal sac. It was quite large, 14.4 centimeter by 8.6 centimeter. The hemodynamics across the tricuspid and mitral valve were okay, normal, except the mitral regurgitation. We measured the RV systolic function. TAPC was 1.69. That means the RV systolic function was preserved. Troponin T and CPKMB were on the rising trend. Creatinine at baseline was 1.8 and it increased to 1.9. He was already a diagnosed case of CKD. The diagnosis to us was clear by now. It was a case of chronic coronary artery disease, acute coronary syndrome, non-ST elevation myocardial infarction with left ventricular posterior wall pseudoaneurysm. Risk factors being male, age, reformed smoker, type 2 diabetes, hypertension, chronic kidney disease, COPD with mild pulmonary hypertension. Because TR max PG was 50, and we also noted that the IVC was of 2 centimeter and collapsibility index was more than 50%. Throughout the hospital stay, he was hemodynamically stable. He refused firmly to undergo any invasive procedure at his own risk, and this is why we couldn't even do TE. And we managed him conservatively. We discharged him after 3 weeks, and the best part is he is alive till the day of this presentation. Coming to the discussion, myocardial free wall rupture takes place in around 2% of the cases of myocardial infarction. It's one of the most underdiagnosed mechanical complications. In non-reperfused cases, the incidence is 6%. In thrombolized cases, 3%. In those who undergo PCI, the incidence is less than 1.5%. Incidence of LV pseudoaneurysm after STEMI is rare, 1.1 to 0.3%, and after STEMI is more rare. It's so rare that it doesn't have any data. There are only a handful of clinical cases described in the medical literature, and ours is one of them. What is unique about our case is it's a pseudoaneurysm developing after STEMI, and the patient is luckily still alive. This is the best part of this story. Thank you.
See, Nilanjan, which is commoner? Free wall rupture is commoner or septal rupture is commoner following MI?
Septal rupture is commoner, sir.
No, free wall rupture is commoner.
Free wall rupture is commoner, sorry.
Most of those people die. That is why we get a feeling that septal rupture is common. It's not like that.
Free wall.
Okay. Can you have interventional treatment in people like this? Because the neck is narrow, it's a narrow neck in a pseudoaneurysm.
Device closure can be tried, but
any data available on that in the literature?
I have read 2 cases. They tried it, sir, device closure.
There are cases both in the acute as well as over a
even in subacute cases, it was tried, sir.
They have done. Okay. How long the patient survived after the SCS?
Sir, he is alive till today.
No. What is the duration of follow-up? I understand.
Sir, it's been nearly 5 months, sir.
5 months. Okay, good.
Coach sir, I don't know whether there is a connection between CKD and this case. I have seen only one case of pseudoaneurysm without ST elevation. Am I surviving? very just like this beautiful.
The CKD is a risk factor for CAD, sir.
Not CAD is, of course, CKD is a risk factor. No, is there any connection between the pseudoaneurysm? Because this case also, for routine pre-op evaluation, for another procedure, she came to us. CKD, there is not even a history of CAHD, but she had a pseudoaneurysm, like this, beautiful pictures, but then same way, patient was not willing for any procedure, she is still surviving.
I had a patient, Dr. Shivaprasad will recollect, that again was an inferior posterior MI. Patient used to come for follow-up. I think patient came for 2.5 years, then
With,
lost follow-up.
With a to and fro murmur. My patient had a to and fro murmur.
And that patient used to come and then lost follow-up. Maybe patient died. Again, not willing for anything.
Free-wall ruptures with pericardial tamponade usually succumb to it. Very little can be done. But those smaller ruptures with a pseudoaneurysm developing with the neck, that can be closed probably with the device.
Because pseudoaneurysm is basically a...
Actually, sir, we discussed with the patient and the bystander about this device closure, but they were not willing for either the surgery or device-related procedure, sir.
No, let me get to your point. We are just telling it for discussion, not about this patient. That is very clear. Only telling that, free wall, it's actually, pseudoaneurysm is actually a contained free wall rupture because of the pericardial adhesions which are present, in some people. That's why everyone do not develop free wall rupture. Everyone do not develop pseudoaneurysm. The usual thing is they develop this free wall rupture, cardiac tamponade, and they die. In some people, it will be limited. So this is actually a limited free wall rupture, which ultimately becomes a pseudoaneurysm and gets organized. Anyway, good case.
Sir, can I make a point?
Oh, sure, please.
Yeah, that you said, I remember vividly the case which you are referring to.
Yes.
Yeah, I had a case in Alleppey, which we wanted to close with the device, and while doing the procedure, before the procedure, we wanted to have just an LV angiogram, and the patient tolerated procedure, but just within half to 45 minutes, patient suddenly collapsed and died. So it is not very easy to do a
certainly
device. The mouth, as we think by echo narrow, may not be really narrow. It may be longitudinally split, and your device may not sit well. So that is one.
That area we do not know whether it is stable enough to hold the.
Exactly.
It's good enough to hold the device. That's it.
It may not be a circular one.
Circular one.
No, because I just referred, there are a few case reports, that is, or not that it's a standard procedure.
That case reports only gave us strength to go ahead.
That may be just one or two case reports, and may not be the standard treatment. Anyway, we had wonderful cases being presented. We had 6 cases and very good presentations. Pilla sir, concluding remarks.
Wonderful session. A lot of learning points and beautiful demonstrations of echoes.
Now we are going to have a tough time to select the award. Dr. Jaber?
I think, sir, we can send the marks individually to Shivaprasad, sir, and he can tabulate and then decide.
Exactly.
And he can also decide how many awards.
I think they all require an award. That's what I feel, because the presentations were very good. But only thing, some of them have connectivity issues, so that they could not join the discussion. But very nicely presented.
Sir, how many
advantage
prizes?
of
One present or two prizes? Is it one prize?
That I think we will leave to Dr. Shivaprasad. How many prizes? He will decide. We will do the marking and send to him. And thank you, Dr. Shivaprasad, for the great honor given to us.
Thank you, Ramasha sir. Thank you, Osha sir. Thank you, Jaber, for this wonderful session.
Thank you for asking me to be here. Thank you.
Thank you, sir.
Can we have the next session, Praveen?
Sir, for the next session, I think Matthew sir has joined it. Yes, he had some problem with the
this thing, connection part. Now I think Sarah's joined. So for the next session, the chairpersons for the next session are Dr. Sunila Vishwanathan Madam, Dr. Johnny Joseph, and Dr. Bino Benjamin. I invite Madam to take over and start the proceedings. Madam, please.
Yeah, I'd like to thank Dr. Sopasad and the organizers for giving me this opportunity. We're moving on to a very, very important talk, a very important upcoming, so many innovations happening in this field, prosthetic valve, function and dysfunction. And to talk on that, we have Dr. Matthew A, a very lucid speaker. I think it's a half-an-hour session. I'm sure it will be very, very useful to all of us. Matthew, Dr. Matthew. I think along with me, my co-chairs are there, Dr. Johnny and Dr. Bino. Can you please come? Have we lost connection or? Hello?
Madam, you're online, but the only problem is Matthew sir has some connection issue.
Can you hear? I am here.
Yes, sir, yes.
Okay, very good.
I am here.
Matthew, good evening, Matthew.
Good evening, madam.
Welcome to the webinar. Nice to see you.
Thank you, madam. Thank you, madam. Can I
Dr.
start?
Bino has also joined it.
Who has joined?
Dr. Bino Benjamin, your
Oh,
co-chair,
very
madam.
good. Welcome, Dr. Bino. Can we start the session?
Yes, sir.
Can I start?
Yes, sir. Please share your screens.
Can you see my slide?
Not yet, not yet.
Yes, madam. Yes, madam. I'm here.
Okay.
My slide visible?
No, sir. No, sir. We are seeing you, but you're not your slide.
Screen
share. Yeah, share.
You are seeing?
Yes, sir. Your slides are visible.
Yeah.
Okay.
And a beautiful house.
Good evening, respected chairpersons and my dear friends. So my topic for today is echocardiographic assessment of prosthetic valve dysfunction. My disclosure, I am not a very dedicated echocardiographer. I must acknowledge my friends, Dr. Subbu Matthew, my colleague, and by Dr. Rajesh, head of the Department of Cardiology, Calicut, for sharing their videos with me. Half of the credit should go to them, both of them. Cardiology is now all about valves. It is all meetings revolves around valves. We have metallic valves, bioprosthetic valves, and transcatheter valves. And transcatheter valves, you already heard from Dr. We had an excellent discussion from Dr. Bijlal. So I like to, this is a last topic. I will pick and choose. I will mainly dealing with metallic prosthetic valves. When we have symptomatic patient with a prosthetic valve, it could be due to prosthetic valve dysfunction, or it could be a ventricular dysfunction, pulmonary hypertension, or other valve affection, or it could be due to other factors. So in echocardiography, we have to concentrate not only on the prosthetic valve, we have also concentrate on the other valves, the ventricular function, pH, all other factors we have to concentrate on. If we have a symptomatic patient with prosthetic valve, we should do a thorough clinical examination, followed by echocardiography, and followed by a fluoroscopy, if required a CT scan. So my talk basically is on echo assessment of prosthetic valve, especially in dysfunction cases. If you have a symptomatic patient with a prosthetic valve, putting it simply, it could be due to three factors. It could be an increased gradient across the valve due to a thrombus, or a pannus, or a patient processes mismatch. Or it could be a regurgitation, prosthetic valve regurgitation, or it could be due to an infective endocarditis and its complications. We have all the modalities of echocardiography to help us, including 2D echo, color, pulse Doppler, continuous wave Doppler, TE, 3D echo, and stress echo. Maybe only the strain rate imaging may not help us in prosthetic valve. All other modalities of echo are important. Before going to the echocardiography, we should collect information about the type of the valve, the date of surgery, the blood pressure, heart rate of the patient, and the patient's height, weight to see the body surface area. Coming to 2D echocardiography and Doppler first. For aortic valve, we have to look at the peak velocity, the mean gradient, Doppler velocity index, EOA, and the acceleration time. For the mitral valve, we have to see the peak velocity, the mean gradient, DVI, EOA, and the PHT. So the difference between the aortic valve and the mitral valve is basically in the aortic process we look at the deceleration time, and whereas in the mitral we also look at the PHT. We'll see each separately. Coming to the peak velocity and mean gradient. Aortic prosthetic valve, we can consider a velocity less than 3 as almost normal. If it is more than 4, it indicates significant stenosis. Mitral valve less than 2 velocity is almost normal. More than 2.5 indicates significant stenosis. There's some problem with the valve. Mean gradient, aortic less than 20, we can ignore. More than 35 mean gradient, it indicates significant stenosis. Mitral valve less than 5 millimeter, ignore it. More than 10, it is significant. So this is a continuous wave Doppler across the mitral valve. You can see the increased gradient across the valve. The mean gradient is around 8 millimeters of mercury. I'm sorry about the video. This has come on site. So mitral prosthetic valve, you can see that there is increased gradient across the valve. Coming to Doppler velocity index. This is a dimensionless parameter which is calculated by taking the VTI of the involved valve along with the adjacent valve VTI. For mitral, VTI of mitral prosthetic valve divided by the VTI of LVOT will give the DVI. For aortic, it is VTI of LVOT divided by VTI of aortic prosthetic valve. You can see the normal DVI mitral prosthetic valve and the DVI aortic valve normal. So DVI is in mitral prosthetic valve, DVI is increased more than 2.2 meter per second, more than 2.2 in the case of a prosthetic mitral valve stenosis. Whereas in aortic processes, the DVI is reduced less than 0.3. Effective orifice area is another important thing we have to calculate. It is calculated from the continuity equation. EOA is cross-sectional area of LVOT into VTA of LVOT divided by VT of the prosthetic aortic valve. And mitral valve is similar. Cross-sectional area of LVOT into VTA of LVOT divided by VT of prosthetic mitral valve. The normal aortic valve, it is more than 1.2, significant stenosis less than 0.8. Mitral more than 2, significant less than 1. Effective orifice area is the most validated parameter for identifying patient processes mismatch. Then we have the pressure half time. This is useful for mitral valve. So you take a continuous wave Doppler across the prosthetic mitral valve, and PHT is the time it takes for the pressure gradient to decay to half its peak value. It's usually given by the calculated by the machine. Normally it is less than 130 milliseconds. Possible stenosis 130 to 200, and significant stenosis if it is more than 200 milliseconds. So it's a very useful and simple tool to diagnose a dysfunction. For aortic valve, we have the acceleration time of the wave across the aortic valve. The normal acceleration time is less than 100 milliseconds. If there is significant obstruction, the acceleration time will be more than 100 milliseconds. You have the acceleration time by ejection time ratio more than 0.4 indicates prosthetic valve obstruction. Coming to an important issue, the thrombus and pannus. We have already seen many videos now. How is it very important to differentiate between thrombus and pannus? Other than echo, if the patient is having acute symptom, likely to be thrombus, whereas pannus is more likely to be chronic. Thrombus usually occurs early after, maybe in the first few years after the valve implantation, whereas pannus is a late complication. Thrombus occurs in a patient having a low INR. Pannus, we may have a flu when the patient is in the normal therapeutic range INR. Thrombus is more common in mitral processes, whereas pannus is more common in aortic processes. Other echo differentiating features are thrombus can occur anywhere on the valve, whereas pannus starts at the suture line. Thrombus may extend beyond the suture line into the surrounding tissues outside the valve, whereas pannus never extends beyond the suture line. If a structure extends beyond the suture line into the LA, for example, for the mitral valve, you can be sure that it is a thrombus, not a pannus. So thrombus is a centrifugal growth, pannus is a centripetal growth. Thrombus, the mass projects out of the valve plate, whereas pannus goes along the valve. So in this picture, you can see a mass projecting into the LA. That indicates it is a thrombus, not a pannus. Pannus is almost horizontal, growing along the plane of the valve. Thrombus is less echogenic, whereas pannus is more echogenic. Thrombus appear more mobile, but it's difficult to demonstrate mobility on the usual echo. Pannus is usually non-mobile. SEC, if seen, spontaneous echo contrast is more common with thrombus, whereas SEC is uncommon if it is not seen, more likely to be pannus. And of course, when you make a diagnosis of thrombus, you are more likely to be correct. That's the odds chance is more. Whereas pannus, when you make a diagnosis of pannus, it is less common. The higher chance you are likely to be wrong. But you have to make a diagnosis because the treatment is different. Can see on the left, there is a thrombus on the mitral valve and cross thrombolysis. The thrombus has disappeared. You can see that the thrombus is projecting into the LA. I'm sorry, these videos that come up on the site. You can see at least you can see a thrombus sitting on the prosthetic mitral valve. The large thrombus. The another prosthetic valve. You can see one of the leaflets is not moving. There is SEC, and the gradient is very high. The patient was thrombolized. Now you can see clearly that the leaflets are moving and the gradients have come down. A very good example of a thrombus and identification of thrombus and effective treatment management. It's an example of a pannus transesophageal echo, mid-esophageal view, 45-degree. You can see a small pannus growing. It is not projecting, it will not project outside the plane of the valve. You can see at almost 6 o'clock position. This is a 3D echo of a pannus. Coming to prosthetic mismatch. So the main causes of a increased gradient across the valve are three. Already covered a thrombus, then pannus. The third is the prosthetic mismatch. Patient process mismatch occurs when effective orifice area of a normally functioning process is too small in relation to the patient's size. So it results in abnormally high post-operative gradients. It is usually seen in aortic processes, not seen in usually in mitral processes. Complications, there's an increased risk of heart failures and cardiac events in such patients. Can index effective orifice area. If the orifice area is more than 0.85 centimeters squared by meter squared, it is insignificant, whereas less than 0.65 indicates severe patient processes mismatch. In obese patients, less than 0.56 is considered a severe patient-prosthesis mismatch. Here are different algorithms for increased gradient across the aortic valve. Different authors have one simple thing is if you have a high velocity and a high gradient across the aortic valve, you do the DVI. If it is less than 0.25, likely to be prosthetic obstruction. If it is more than 0.25, check the aortic acceleration time. More than 100, it could be an underestimated gradient across the valve due to LV dysfunction or something like that. If the acceleration time is less than 100, you check the effective orifice area. If it is low, likely to be patient-prosthesis mismatch. If it is EOA is normal, it can be due to high flow across the valve. So this is in a nutshell, the algorithm, how to go about differentiating between a prosthetic dysfunction, patient-prosthesis mismatch, underestimated gradient due to LV dysfunction, or a increased gradient due to high flow. Coming to valvular leaks, prosthetic regurgitation could be physiological or pathological, and pathological could be valvular or paravalvular. Most of the valves have some degree of regurgitation, and this is physiological. Could be due to a closing volume or a mild regurgitation of the hinges of the occluder. How to differentiate a physiological from a pathological? Physiological is usually homogeneous in color, with areas confined to the origin, narrow at the origin, jet is narrow at the origin, and it is usually a short jet. And paravalvular leak is the most important. It's defined as demonstrated by color Doppler originating between the outer margin of the swingment and the native tissue around the valve. You already heard about it. Less than 10% circumference is mild, 10 to 20 is moderate, and more than 20 indicates severe. And T is, of course, superior, indicating prosthetic mitral regurgitation or any aortic and mitral regurgitation. T will help to differentiate physiological from pathological flows, define the degree of regurgitation, identify the shape and size of the regurgitant orifice so as to plan a intervention. Again, sorry about the video, it has become on site. There's a mitral valve prosthesis T showing severe regurgitation. It is striking on the vein ligament of Marshall. This patient is presented with severe hemolysis to Dr. Rajesh from Calicut. So TE of a paravalvular regurgitation, 3D Doppler. So based on the Doppler, we have to not only quantify the regurgitation, we also identify where the regurgitation is, and so as to aid in the crossing of the defect and closure. Coming to infective endocarditis, that is an important complication. It's difficult to detect in 2D echo, may involve the suturing and annulus producing paravalvular abscess. So the important thing is to differentiate between vegetation and thrombus. Vegetation, we all know it's patients may be febrile, having normal INR. So vegetations are usually near the swinging, more mobile, and maybe associated. There is a valve abscess likely to be vegetation. And perivalvular complications are common in early prosthetic valve endocarditis. So you have to search for a perivalvular abscess when you have an early prosthetic valve endocarditis. And it's more common in aortic valve than a mitral prosthetic valve. What is the role of stress echo? Is there a role? When you have a patient with suspected prosthetic valve dysfunction and the 2D and Doppler echoes are normal, but we still strongly suspect, we can do an exercise stress echo and elicit abnormal hemodynamics, which may bring out the dysfunction. Bioprosthetic valve degeneration, thrombosis may be seen. An increase in gradient more than 50% from the basal is significant. Increase in cusp thickness more than 2 millimeter. Abnormal cusp mobility. Direct visualization of thrombus. They are all very important in diagnosing dysfunction. It's a case of a bioprosthetic infective endocarditis with a vegetation and a perivalvular abscess. Thank you. I think my time is up.
Thank you, Dr. Matthew. There is a very elaborate discussion because,
Thank you, madam.
yeah, because it's such a large topic. And what I would like to reiterate is that oftentimes the clinical picture of the patient, what valve has been used, the body surface area, the height, the weight, the immediate post-op echo findings, all these are to be documented and kept till the last time. The patient has to be advised to do that and bring it on follow-ups because we don't have it most of the time. So it is important to document that and have serial assessments over time. So that is one thing which we unfortunately some of them. And prosthetic valve is a very bad disease. Actually, it's a bad disease. Now, we were talking about thrombus and sinus. But the very nice differentiation which you have put up, very nicely elaborated. Now, I'd like to ask one thing about the prosthetic valve regurgitation, paravalvular beads versus the closing, the washing jets. How do you differentiate?
What is the when you have a process when the regurgitation is significant, not significant is a homogeneous jet. Color aliasing will not be there. It is a narrow jet, and the length will be short. The shorter the jet, the more likely it is likely to be physiological. The broader the jet, likely to be pathological.
Yeah, and one point I'd like to add is probably these jets are within this washing jets or the closing jets are within the suture.
Yeah.
They're within the suture. They're never away from the suture. Sometimes people describe it as crossing each other also. Dr. Bino?
Yeah, sir. Sir, it was an excellent talk. Lot of learning points. It was excellent. So the assessment of this valve functions, it was very clear. But one thing which we usually follow, one is dimensionless index.
Yeah.
So that was very useful, and it's easy to calculate when you assess this LVOT, aortic valve. So would you like to, or you, because it was exhaustive, you missed it out, or?
No.
He mentioned.
He mentioned it. Matthew did mention
Oh,
it. Can you, if you have your slide sort of, can you put it up? That,
Yeah, maybe that time I missed it out, sir. Maybe.
Yeah.
I'm sorry for that. But anyway, it was very exhaustive.
And another, so Matthew has time, you can do that. Another thing is that the aortic flow acceleration time.
Right. Yeah.
More than 100 milliseconds, very useful point. Matthew,
I mentioned it.
You mentioned it. So I'm just underlining in one spot. So we don't usually look at it, but the tongue shaped septum and the flow and the time from onset to the peak being more than 100 milliseconds. Immediately it suggests that there is a big obstruction versus, right, Matthew? Is that the thing that you were telling?
Yeah, pardon, madam?
There is a time to acceleration.
Yeah,
and
less than 100.
The contour of the flow
Yeah.
through
Yeah.
the aortic valve. So that is indicative of. Can you show that slide? Sort of the you can just read it because you put like if the DVA is less than 25, it is 0.25, it is obstruction, and then you have the other two scenarios. Next. That option. Yeah, this is. I think we should always be on the record for this. Very easy. And it will help. Now, can you show the other one also? It's a combination of the acceleration time plus the DVA. That algorithm.
Algorithm, yeah.
Algorithm.
But actually, I simplified it.
Yeah.
So,
This is the one, you know.
Yeah.
Yeah, this one.
Yeah.
It's very difficult to get this much precise data from any of the textbooks.
Yeah, actually, I simplified it.
No.
Yeah.
I hope you got the permission from the AHA.
So DVA less than 0.25, Matthew, why don't you just explain?
DVA less than 0.25, it's a high likelihood that it is a prosthetic obstruction.
Okay.
Whereas more than 0.25, you do the acceleration time.
Okay.
More than 100 acceleration time, you are you are underestimating the gradient. Less than 100, you check the effective orifice area. If it is low, it is patient processes mismatch. If it is normal, it is due to high flow.
That means in patient prosthetic mismatch, the acceleration time will be less than 100 milliseconds.
Less than 100.
Okay.
Sorry for myself being late. Dr. Johnny here. I had a primary, but I really enjoyed your talk. The very comprehensive discussion, especially pious versus thrombus. I have never seen such a comprehensive slides. Really enjoyed it, and have nothing to add. Discussion was also good. The point Sunita made was excellent, because many of the time when the patient is coming in a critical moment, they don't have any data, or we don't have any clue what process it is. It's really important nowadays. Anybody can picture it and stock in their cloud. So I think it has to be there.
Madam, can I add something?
Yeah,
sure.
Yeah. So if you are using looking at bileaflet prosthetic valve, especially in the mitral position, we can look at 3 measurements, which is cine fluoroscopy is better, but even on TE, that closing angle, opening angle, and travel angle. So opening angle in the normal prosthesis is about 10 degrees to 11, 12, like that, and the closing angle around 120, 115 to say 120, and travel angle, that is different for different products, but still we can see a difference in the travel angle. One travel angle is less than the other. So then you can suspect that dysfunction.
I think that means a stuck lead.
Yeah. So we can separately look at the travel angle of each disc. That's very well seen in fluoroscopy. Fluoroscopy is the best thing, but TE, especially for mitral prosthesis, you can clearly see that.
And nowadays,
The one in one case where which I showed, that one leaflet was not moving, so that the travel angle is very little there, and in the other was normal, but 45 degrees.
When CT is also supposed to be good.
Fluoroscopy best, especially except for Chitra valve, fluoroscopy will be the best for assessing a prosthetic valve, duct valve.
Thank you, Rajiv.
So I think we had a very good discussion. Are we on time?
Yes, ma'am. It was just 1 minute past. So thank you.
1 minute past also. Okay. So thanks to
My fault.
Thank you, Matthew sir, for the excellent and simple presentation of a very
Thank you for inviting me.
And the chairpersons also equally justify their role with the excellent discussion. We just kept 10 minutes, and that is not enough, I think. The discussion was such an excellent. So thank you all. Thank you all. So we move on to the next presentation, which is again one of the most awaited presentations by one of our international faculty. That is regarding assessment of mitral valve for mitral clip. And sir is from the University of Arizona. Is an international figure from India and from Kerala. I asked the chairpersons for this session is Dr. G. Vijayaraghavan sir, Padma Shri Dr. G. Vijayaraghavan sir, Dr. Sajeev CG, and Dr. Rajiv sir from which he asked. I asked them to take over the proceedings.
Thank you. It's a very important topic coming up. The echo assessment prior to mitral clip. For mitral clip, the echocardiography is probably more important, equally or maybe more important than the interventionalist himself. Because in various phases, when we decide whether mitral clip can be done, it's feasible to do, it's appropriate to do, then during procedure, during septal puncture, then guiding the device across the mitral valve, then seeing whether it's appropriately orientated,
and looking at the results. So everywhere the echocardiograph has a major role. To talk on this and more, I invite Dr. Raj Janardhan. Dr. Raj, please.
Thank you very much. Thanks for the kind introduction. I hope you can hear me. Can someone confirm you can hear me okay?
Yeah, we can hear you very well.
Yeah, we can hear you. We can hear you, Raj.
Okay, wonderful. Thank you so much. Okay, all right. So I'm going to just share my, hope the slides are.
Yeah. Very well, very well.
Okay. Once again, thank you all for this kind invitation. It's 7 a.m. here in Arizona, so perfect time. Let me start by thanking Dr. Shivaprasad for the not only the opportunity, but also adjusting the time that is convenient for this lecture. So this is a relatively short topic, and it's a more focused topic on the echo assessment prior to transesophageal edge-to-edge or transcatheter, I would say transcatheter edge-to-edge repair in the mitral valve. And to make it simple, I'll probably use mitral clip, which is much easier than using the newer nomenclature TEER. So I'm a professor of medicine, medical imaging here at the University of Arizona. Obviously, my roots are all back in Trivandrum Medical College, and I'm so honored to be here and proud to be here amongst, I see Dr. Sunita, Dr. Shivaprasad, and I also saw Dr. George Koshi a little earlier, along with the others, Dr. Matthew, etc. Once again, thanks very much. So let's get going. So the mitral clip of the TEER is based on the Alfieri stitch, and that's the original stitch that was offered by the Italian surgeon in an effort to reduce the effective regurgitant orifice area and try to make the mitral valve orifice into a double orifice, and again reduce the EROA. And the idea is to reduce the amount of regurgitation. So this was the concept based on which the mitral clip was developed as initially an experimental procedure, and they tested out in animal models first, and they found that why don't we translate that into a procedure and as a device. And now we have not only data on the safety, we have data on the efficacy, but also some data on the durability, at least 5 to 10 years after those initial experiences. So this is what we would like to get to right at the end, and you have your clip here. This is just an illustration of the device in place. Again, I will not go into the actual procedure itself because that is a totally separate topic. But one slide on the device, you have the mitral clip arms, the grippers, which can be raised and lowered, and they can be raised and lowered independently in some of the newer devices. But in the older devices, which is the NT version, they would be deployed simultaneously. But now we have different devices where you can approach them and deploy them independently. Again, as I mentioned, that is not the topic for today. So the topic for today, at least for this 15 to 20 minutes or so, will be on the pre-procedure, and we use TEE here in the US, and the vocabulary or the semantics would be TOE in India and in the UK. But for ease, I will use TE. That's okay with you all. So we are using echo and transesophageal echo, and we are going to look at how do we assess the candidacy, or which are the patients who are going to be suitable for this clip procedure. So these are some of the essentials. Again, this is not a full list. These are some of the lists I jotted down as I was preparing. So we need to have, it has to be a comprehensive TE evaluation. But first and foremost, we have to document the MR is significant, and that's grade 3 or more. Again, the mitral procedure as well as the evaluation is not just 3D, very important. So although I said information from 3D TE, the 3D aspect is only a part of the actual evaluation. It's a combination of three-dimensional echo with surgeon's view, which we will talk about briefly, but also a proper assessment using 2D as well as Doppler of the mitral regurgitation, and try to differentiate whether it's functional or degenerative. That is good to know, because the original trials were all done on, if you think about the Everest trial, that was on degenerative mitral valve disease. But then that has been extrapolated further in COAP and MITRA FR to functional MR as well. Then try to identify the location of the jet. That is going to be critical, and we will definitely cover that. Ideally, we are looking for those central jets going through A2 and P2 and avoiding the non-commercial jets. Extremely important to document that the valve area is at least more than 4 centimeters square. Reason being, the patients do not tolerate, even the patients with mild mitral stenosis or borderline mitral stenosis will not do well with the mitral clip procedure. So it's absolutely critical to make sure that the patient does not have any grade of mitral stenosis. We need to properly assess the grasping area and document that there is enough, not only that is enough leaflet length there, minimum cutoff being about 7 millimeter, but there is also no calcification in the grasping area. Deep clefts are usually not good for the clip, although there are case reports of successful cases being done. But in general, if you have a deep cleft, that would be the challenge for the mitral clip procedure. Favorable atrial septal anatomy, I will briefly mention that. And that is essentially looking at the amount of transseptal distance that will be available for the actual procedure. You need to have a minimum amount of transseptal distance for the procedure. So again, a chart, again, this is constantly evolving. So this is not up to date, and this is constantly being evolved. And the reason I say that is many of the criteria that is listed here tend to become obsolete as we develop more and more devices. But in any case, for the sake of completeness, I have put this slide looking for what is the optimal or the ideal candidate for the mitral clip procedure, right? The ideal candidate would be somebody who has significant MR from a central pathology coming from A2 and P2. And why A2, P2? Because the device was originally designed for a central clip, and the central clip would be where the MR is originating from A2 and P2. Again, as we mentioned earlier, there is no leaflet calcification, mitral valve area more than 4 centimeters square. We have a mobile posterior leaflet length of 10 millimeter or more, a coaptation depth of at least of less than 11 millimeter, so that there is ideal coaptation between the leaflets. It should be normal leaflet strength. That means that it's a healthy leaflet, and the flail width being less than 15 millimeter and the flail gap less than 10. As I mentioned earlier, these are all the original Everest criteria for what would be considered as an ideal valve for the clip. Let's skip this conditional. Let's go into the non-suitable. And this is probably something that is still going to be relevant. Perforated leaflets are not going to be ideal because there's no way you can put a clip in a perforated leaflet. Severe calcium is usually an absolute no-no. The reason being for 2 reasons. Not only you won't get a good grasp of the leaflet, but typically patients with severe calcification will have some degree of mitral stenosis, at least borderline mitral stenosis, which would make the clip not a possibility. We talked about the mitral valve area and the mean gradient. Again, these are not hard and fast, but in general, we use a gradient of less than 5 for the sake of completeness, for the sake of ease, I would say. A leaflet length, again, less than 7 millimeter. It's a good kind of a guideline, but there are several cases, including us in practice. We are sometimes able to get shorter leaflets, but those are usually challenging and much longer procedures. Rheumatic heart disease, usually patients, even with the valve that tends to appear to open, is usually there is going to be some element of restriction, which means at least some degree of mitral stenosis. Barlow's valve can be challenging. Again, these are not absolute contraindications, but I will show you examples where how this can be potentially challenging. Again, the concern being that of developing mitral valve gradients. So let's look at what is the ideal mitral valve for the clip. And as I mentioned, this does not always happen in real life, but this was our first clip case, and the patient was carefully chosen so that we will get our first clip, because that was the one we wanted to make sure that we are successful. So this was carefully selected patient who had a central jet of MR. Now, if there are any trainees listening in, I want to remind everything that you have to apply everything that you know in the assessment of mitral regurgitation. on a TEE with under sedation, right? So you do have the concern of underestimating the valve area, not only the area, the amount of regurgitation in the presence of sedation. So keep those simple things and common things in mind when you assess that. This is not unique for the assessment for the mitral clip. So if it is so much of MR in the, again, this heart rate is faster, but in a slower heart rate, if this was the amount of MR, it's likely to be torrential if you're doing a thoracic echo when the patient is with a normal blood pressure. So those are all things that we have to keep in mind when we assess any patient with mitral regurgitation with TEE under sedation. I use a lot of color and color compare, which is a great tool where you have your side-by-side display of the mitral regurgitation jet, as well as the 2D image on the same panel. It's a nice way to document not only the location of the jet, the origin of the jet, as well as the amount of mitral regurgitation. So here, even on 2D, you can clearly appreciate there is more than one jet origin, which suggests that this is possibly not going to be a one-clip case. So these are things that you start to keep in mind when you go along the case while you're acquiring images, that this should be something that you're constantly thinking ahead, and make sure that these are all documented and reported so that when the patient shows up for the clip, the operator knows that, okay, this is not going to be a one-clip case, it's going to be more than one clip. Next, we move on to 3D, right? When we are assessing color, again, it's a comprehensive assessment of the color jet, not only on 2D, but also on 3D. And here, this is a live 3D image. I won't go into the technical aspects of the 3D imaging because that's a different topic. Here, the assumption is made that you're already fairly advanced in your experience and exposure to 3D technology. So this is adding 3D to the color jet, or adding color to 3D. Either way, you can look at it in both ways. And the idea of this image here is to make sure that there are no peripheral jets and it's a central jet. Again, we can go back to our standard 2D PISA. This is our standard 2D PISA, where we adjust our Nyquist limit and measure the PISA radius so that we can have, and this is pretty standard PISA measurements on TEE, similar principles as we use in 2D in transthoracic echo. Now, this is moving on to a 3D PISA. Again, this is all assessment, and this is still part of, in the guidelines, they have used this, although these can be challenging. I'm just using this slide to show the principle of how you measure 3D vena contractor area, where you measure a 3D color data set, and then you bring it to what is called MPR, multiplanar reconstruction. And if you look at this, if you look at this panel here, that would be our 3D VCA. You can magnify that and then do direct planimetry. So that is our 3D vena contractor area. What's most important is the next few slides, and that is a proper surgeon's view assessment of the mitral valve. In my opinion, these are the views that gives us the best value in planning ahead on what to expect, what are the challenges, or how easy or how difficult the procedure is likely to be. So here is an example of a surgeon's view, and this was a patient actually who had dilated cardiomyopathy, severely dilated left ventricle, although you can't see the ventricle on this view, but you can see here there are some degenerative changes, but this is not a classic case of prolapse or flail. This is just dilated ventricle, and you have areas of malcoaptation. If you see this kind of image, you can already predict that there is going to be significant mitral regurgitation and not a case that can be settled with one clip. So this patient, in fact, ended up, even without adding the color on, you can plan ahead and prepare and anticipate that this is likely going to be significant mitral regurgitation with more than a need for multiple clips. So this is another example. I'm just showing you some classic cases, to keep it real simple. This is the classic P2 prolapse. Again, to orient, if there are any trainees on this in the audience, that's your aortic valve, and that's a mitral valve. That's the right coronary cusp, left coronary cusp, non-coronary cusp, and this is our intraatrial septum. So that will be our non-coronary cusp, anterior leaflet, posterior leaflets, A1, A2, A3, P1, P2. So the prolapsing leaflet is P2, and that is P3. So this is an isolated P2 prolapse. Again, I'm showing cases who are non-surgical candidate. If it's surgeon who is seeing this case, the surgeon would be super excited operating and with a mitral valve repair, which is an easy repair for an isolated P2 prolapse. But this was a patient who was a non-surgical candidate who needed to go for a mitral clip. Again, that's the LV view, which is not really useful in this particular case. But this is the image that is of interest, and that should be the image that goes into the report. Again, the focus of today's topic, I have a few more minutes left. I'll try to wrap it up. You have got true view imaging. This is just adding transillumination to our standard 3D imaging. This is a relatively newer technology that has been available in many of the vendors. This one is from Philips. It's called TrueView. However, the same technology is available in multiple vendors. And you have your touch screen. You touch the screen, you have your light source in the left atrium. You can touch the screen here. You have your light source in the left ventricle. Again, it just demonstrates a P2 prolapse, a different patient with an isolated P2 prolapse. And here you are leveraging the benefits of using the light source and the shadowing in highlighting the prolapsing leaflet. In this case, it is a P2 prolapse. This is a different patient. These are more challenging cases. Again, the idea of showing these slides are giving you multiple examples of how the surgeon's view can be useful. This patient obviously had a more challenging flail. This is a P3 flail. This can be challenging. So these should not be your first cases. If you're starting a MitraClip program, you should kind of hold on to these cases and attempt when you are really gained some more experience and exposure. So that is a P3 flail, or get closer to a commercial flail. Here you have got multi-segment prolapse, but this is again prolapse of the P2 and P3 primarily, along with some other degenerative changes in rest of the leaflets. This is the classic still frame from a patient with multi-segment prolapse or Barlow's valve, and these can be extremely challenging. As you can see here, these patients can have a wide variety of mitral regurgitation. This patient had, I'm just showing you an example of Barlow's valve. This patient had minimal mitral regurgitation, but let's assume this patient had significant mitral regurgitation. You can see that these are really challenging to put a clip because you have a high chance of developing mitral valve gradient. This is more challenging in this particular patient who actually went for surgery and they attempted a repair. And the reason for this not being a great MitraClip candidate is you have multiple areas of malcoaptation. So you got multiple jets of MR. So you can start putting clips, all the way from here to there, and you will still not get a good result, ending in significant gradient. So this particular patient went for surgery. They attempted a repair, and obviously it was not a good result, so ended up getting a replacement. Now, staying on the surgeon's view, you can leverage by adding color to that, and now you have got color 3D on the surgeon's view. And the value of this is to locate the jet, the origin of the jet, where exactly the clip should be placed, so on and so forth. For here, this was our first clip case that we tried. So as I mentioned, this was a carefully selected patient who had a problem in the central jet between A2 and P2, and we were able to take care of this with a single clip. We just used one small single clip, and that was able to take care of this jet. So these are what would be the ideal candidate for the MitraClip. This is yet another Barlow's patient. Now you can see here multi-segment prolapse, as you can already see from here, thickened leaflet, myxomatous leaflets. Again, the challenge here, if you can carefully pay attention, is there is a deep cleft, right? And I'll show it to you right here, and in a different view right here. There's a deep posteromedial cleft. These are challenging cases for the clip procedure because there is no tissue when you have a deep cleft. There is no way you can grab. You can put a clip between A2 and P2, maybe between A3 and P3. You're just going to make the cleft worse. So deep cleft is going to be a problem. And the proof is in the pudding. You have to document that the mitral regurgitation is originating from that posterior cleft, and that would not be, the patient will not be a good candidate. This patient ended up going for surgery. He did okay, and they were actually able to repair this, and they were able to repair this valve. So again, at the hands of a good surgeon, and they are able to sometimes take care of challenging Barlow's valve cases. And he ended up getting, actually they put a stitch here, kind of an alveoli stitch between P2 and P3. Again, this is a broad, just again, examples, multiple examples of using the value of color added onto the surgeon's view. This was a 3-clip case where there was a broad jet of mitral regurgitation. Again, another example of 2 jets. I think I have 7 more minutes, so I'll wrap it up. This is lateral jet. I'll quickly go through this. Again, I want to be cognizant of the time and not go over the allocated time. So this is using transillumination and some of the newer benefits that we have. These are all extremely helpful for a successful mitral clip case, right? So here again, you have a patient. Obviously, you can see some restriction of the posterior leaflet. Again, a broad central jet. And if you look at this case, you can see that this is going to be an easy patient, and easy in the form of a central clip would take care of this. You can see a central malcoaptation. So using our current technologies, this would be an ideal patient for a clip between A2 and P2. Again, a broad central jet, going back to the principles that we have already been discussed. However, with the latest tools that we have of transillumination and transparency added, which is a glass view and true view, you can see the real malcoaptation is not quite between A2 and P2. It's actually happening between A3 and P3. Okay, you can see here. And these are using the newer tools that are available for the last 2-3 years now, which is using glass view and true view. Or if you again are talking in more simpler language, it's using the benefits of trans-illumination and transparency, right? And then when you add color to the glass view, you can see that the jet is, yes, it's a broad jet, is primarily originating from A3 and P3, and this patient would benefit not from an A2 P2 clip, but from an A3 P3 clip. So these are the newer technologies that are available, which helps us finesse where we need to put these clips rather than just a random clip in the middle and then creating gradient. So again, I think I'm running out of time, but I'll just show you one example here. This looks like an A3 P3 jet, but if you pay attention, and this is where the cine imaging is going to be helpful. The jet is actually originating from a central jet, and it is emanating medially, right? So, and this is the importance of having a high frame rate image or high volume rate. If I show you this still image, so the clip should be placed at the origin, which is at the A2 and P2. As a patient with 2 jets. And finally, I have a couple more slides where we have to measure the gradient, and this is the mean gradient. Here it is 1, and we do not want any patient with a resting gradient of 4 or 5 at rest. You need to be extremely careful before you put a clip. A couple more concepts which I have to cover is the transseptal distance. So you have to measure what is the potential transseptal site here. This distance would be around 4 centimeters. That is the minimal distance that we need. So you need to measure this distance right here of 4 centimeters. And this is a patient who had a relatively short, again, the LA is dilated, but the LA has dilated along this path. So you can see here, the distance is pretty short. So this would not be a suitable candidate for the mitral clip. And finally, before we wrap up, we have to document the pulmonary veins, and not only just one pulmonary vein, you have to document all the 4 pulmonary veins and the color flow, as well as looking at if there is any flow reversal. So I'll stop there. I have like 4 minutes left. I apologize for going a little over, but I'm still stopping before my session ends. So that's my Echo Lab. That's a group we have. I just wanted to thank the group here, Dr. Vijay Raghavan, who has been, who made me fascinated in this field of echocardiography beyond cardiology. So he was my first guru who made, I was just absolutely fascinated by this technology of echocardiography. And I saw Dr. Koshi earlier, and this was during my visit back in 2014, when I had the opportunity to meet everybody and present at Trivandrum Medical College. And this one was very recent. Again, thanks to Dr. Shiva Prasad for the invitation in July to visit Medical College Trivandrum, and once again here for this lecture. So I'll thank you for your attention. I have like 3 minutes left for discussion. Thank you.
Thank you, Raj, for that excellent demonstration of various aspects of mitral evaluation before TIA. And the 3D has really made a big difference. So especially that multiplanar reconstruction, assessing the severity, regurgitant orifice measurements, and the glass view. So everything has really made it much more simple. Especially for surgeons, it will be a very easy for them to understand. Normally, if you show them a two-dimensional TE, they won't be very happy to look at it. But I think this mitral valve on as view from the LA, so they are they understand it very well. Excellent. Okay. Thank you.
I'm happy to take any questions. I think we have 2 minutes, so happy to take.
Very informative talk. Post procedure, which is the method for assessing the mitral regurgitation.
I'm sorry, I didn't catch that question.
Post procedure, what is the best method to assess the MR? Because PISA and all will be standard from.
Right, post procedure. Okay, so absolutely. So transthoracic echo, whether it's so basic, but that is your go-to post procedure. On the TEE, we are looking at a couple of things. We are looking at most important, how much are these clips still grasped or in place, right? There is usually no shifting that happens, but if has there been any shift in the clip, that is one thing when you're doing TEE. So going back to your question, there are 2 ways of assessing it. TEE, transthoracic echo. On the TEE, you're looking at, are the leaflets in place? Is the clip in place? Is the grasping optimal? Is any part loose? Has the clip actually detached from any of the leaflets? That is a problem, and that can happen. Has the worst case scenario, has the clip embolized, right? Then looking at that, you can do a planimetry and on 3D of the valve orifices. Then most importantly, you can measure the gradient, right? You can measure the gradient between on the jet. So it is a combination. In addition, that is not the topic for now, but again, it's a very loaded question. You have to look at the pulmonary veins, right? Before and after, if there was a flow reversal, whether there has been some improvement. If the clip was done correctly, you will see some improvement in the pulmonary vein profile.
Is the threshold for intervention different between primary and secondary?
The threshold for okay. So primary and secondary MR. Well, not necessarily from the regurgitation point of view, not necessarily, no, because we are looking at the same thing. Secondary MR is going to be more challenging when it comes to percutaneous closure, because there can be, and depends on the degree of tethering of the posterior leaflet. And when you have extreme cases or severe cases of functional MR, especially from ischemic, there's going to be fibrosis and shortening of that posterior leaflet and extreme tether. So if you have an extremely tethered case where the posterior leaflet is almost short and fibrosed and plastered, and maybe 5 millimeters, 6 millimeters, those can be challenging. So between degenerative and functional MR cases tends to be more challenging. And if you have a very dilated left ventricle with significant amount of malcoaptation and which are apically displaced leaflets, to grasp them can be more challenging.
Okay. And that's what you said. Coaptation depth is more than 11. You said it is fairly
That's right. That's right. But we don't necessarily actively go by absolute cutoffs. We look at everything, right? We look at everything. For example, where I'm to go back to that question, where we don't look at the absolute cutoffs is, suppose you have an already restricted leaflet, already restricted valve, where you have only room for one leaflet, one clip, then all these numbers don't make sense. I think we are over time.
Thank you, Raj, for that excellent talk. Thank you very much.
Thank you.
Thank you. Thanks for the opportunity. Appreciate
it. Thank you, Dr. Raj, for readily agreeing for coming to and attending our this IAE Kerala chapter meeting. And thanks all the chairpersons for making the discussion very lively. So we now move on to the next session. That's the last. Include them. For this to share this session, we have Dr. Rajesh from Amrita Institute, Kochi, Dr. Ramakrishna CD from Kannur, Government Medical College, and Dr. Bijumon from Government General Hospital, Kochi. Over to the chairpersons.
Yeah, good evening, everyone. I want to thank Dr. Prasad for this opportunity. We're going to the last session of this great meeting, and we've got 6 interesting case presentations from different hospitals in Kerala. And each presenter has 7-minute time and 3 minutes for discussion. And then we will see how things go about. Let me invite the other chairpersons to also take over. Dr. Ramkrishna is here. You can see Dr. Bijumon also.
Yes, sir, I am also here.
Yeah, welcome everyone. And can we have the first presenter, please? Please.
Good evening, respected teachers and respected chair. I'm Dr. Ambadi from Government Medical College, Trivandrum. My mentors are Professor Dr. K. Shivaprasad sir, Professor Dr. V.V. Radhakrishnan sir, Dr. Matthew sir, and Dr. Sibu Matthew sir. Today, I am going to present a case which came to our OPD with complete heart block. I have titled it as Unveiling the Mystery Behind a Complete Heart Block. The history goes like this. Our patient was a 40-year-old lady who presented with multiple episodes of pre-syncope and dystonia exertion, functional class for the last 6 months, which slowly progressed to functional class 3 for the last 1 month. So she came to our OP and was evaluated, and we have taken an ECG, and it showed that the initial ECG showed a 2:1 AV block, which later progressed to a complete heart block. This was a ECG which was taken at the first consultation in our hospital. This ECG showing 20 ECG showing a 2:1 AV block with heart rate approximately 60 per minute. Actually she progressed from second degree AV block to complete heart block. I couldn't get an image of that ECG showing the complete heart block. So to find the cause for this complete heart block, actually we did an echo for this patient on the same day when she visited our OP, and the first view was the parasternal long axis view showing the LA, LV, the aorta, and the RV outflow tract. The parasternal long axis appeared normal. So going to the next view, this was the mode across the aortic and mitral valve. The dimensions were normal. The aortic root was diameter was 3.3, and the LA dimension was 3.7. It was within normal limits. Coming to the next view, it is the parasternal short axis view at the level of papillary muscles, showing evidence of any LV dysfunction. And we calculated the EF, and the EF was found to be 64.9% preserved ejection fraction, and the LV IDD was 4.42 and 2.86. The dimensions are within normal limits. And next we had the apical 4-chamber view. Actually, the striking thing to notice in this view was we can see a hyperechogenicity in the basal inferior and infralateral segments. Just because of this thing, this hyper, which is not normal in normal patients. So with the background history of this complete heart block and the echo showing hyperechogenicity in the basal inferior and infralateral parts, we suspected some infiltrative disease based on this finding. This is actually a 2-chamber view where you can see more clearly the hyperechogenicity in the inferior basal, infrabasal and infralateral segments. This is the E by A, which shows that the E velocity of 88.3 and the E by A ratio is 2.1. It's showing diastolic dysfunction of stage 2. The E by E prime was found to be 24. All this suggestive of diastolic dysfunction, stage 2 diastolic dysfunction. And in the 4th chamber, the color view showed a trivial MR. The max PG was only 20 MR. So with this background, we were suspecting an infiltrative disease like sarcoidosis, which is not very common to produce a complete heart block. But since we have seen the hyperechogenicity in the 4th-chamber view, we had a doubt about this infiltrative disorder like sarcoidosis which might result in complete heart block for this patient. So after the echo, actually we did a GLS imaging which showed cherry on top appearance, which can be seen in sarcoidosis and other infiltratory diseases. So to confirm the diagnosis, actually we had taken a cardiac MRI where we can see that there is delayed gadolinium enhancement in the basal androseptal and basal infralateral segments. We can see clearly the enhancement, the gadolinium enhancement in the cardiac MRI. Especially we can see it in the androseptal and the basal infralateral segments. And by doing this, we have almost confirmed that the patient is having sarcoidosis. And actually, we have sent a, the patient was having lymphadenopathy. So actually, we sent a sample, biopsy sample also for this patient, and it came positive for this sarcoidosis. And the patient was started on steroids. And the patient, after 1 or 2 months, the patient progressively became better, and the complete heart block was turned to normal sinus rhythm. With then the patient is hemodynamically stable, and the patient is currently doing well. Because of this rare finding, hyperechosis, which is seen in the echo, we went on to proceed to find the etiology behind this complete heart block, and it's very rare to have some infiltratory disease causing, like sarcoidosis, causing a complete heart block, and we were able to find the cause for complete heart block as sarcoidosis. So we should suspect such infiltratory disease when while dealing with patients who come to us with second degree AV block or complete heart block. Thank you.
Very nice presentation. Can I ask questions? Yeah. Okay. After the echocardiogram, what are the other differential diagnoses we can consider in this case?
There was not much finding in the echo. The other, the EF everything, but I told you suspicion was this hyperechogenicity only we have some doubt. The other things were within normal limits. Correlating with this symptoms for complete heart block. Stage 2 diastolic dysfunction was there, probably what cause for the dyspnea on exertion.
Any other? So did you consider amyloidosis?
Yes, sure, sir. Some infiltrate, we are actually concerned about amyloidosis or sarcoidosis.
So what are the usual findings of amyloidosis in echocardiogram?
This sparking appearance, sparing will be there.
And septal dilatation.
Septal thickening of dilatation will be there.
Usually the differential, usually septal dilatation, then usually seen in amyloidosis.
Yeah, apical sparing is possible, no? In amyloidosis.
Yes.
If you do a GLS, you get a cellular spot.
Yeah,
yes,
good presentation. I think we'll go to the next presenter. Or Bijuman wants to ask any question? Okay, we'll go to the next presenter then in that case. Thank you very much.
Bijuman sir is muted.
Thank
you. Sir, I just wanted, hello?
Yes.
Yes, sir.
In cardiac MR, were there some other findings in the medial sternum or in the pulmonary findings? Which is
no, sir, actually. Actually, some mediastinal lymphadenopathy was there, sir.
So what do you think the etiology of the complete heart block in this case?
I think, sir, probably because of the infiltration. Yes, sir, probably cardiac infiltration. As suggested, gadolinium enhanced. It's suggestive of actually infiltrated.
With steroid treatment, what happened to the rhythm?
Actually, the patient initially it was complete heart block with to second degree and finally to AV block and sinus. So we had done a biopsy also for this patient. It came positive for the sarcoidosis and non-caseating granuloma. So came as positively suggestive sarcoidosis. We have started on steroids and the patient actually gradually improved on 2 to 3 months.
Reverted to sinus rhythm. Okay.
Yes, sir. Yes.
Okay. Fine.
Okay. Thank you.
Thank you very much. We'll go on to the next presenter.
Good evening. Myself, Dr. Nikita Saif, the RNP cardiology resident, DC Hospital, Ernakulam. So I have a case with you, pondering over the stuffed door, case of mitral valve thrombosis. So we had a 50-year-old female, a type 2 diabetic, diagnosed with rheumatic heart disease and severe MS at the age of 40 years. And she underwent a mitral valve replacement with St. mechanical valve in 2013 and on oral coagulants. She was on regular follow-up in the OPD. Now, last 5 months, she has been experiencing worsening of her dyspnea, and she came to the OPD with the same complaint. But there is no history of any recurrent fever, weight loss, orthopnea, angina, or hemoptysis. So, in admission, the patient was SFI, her heart rate 70 per minute, regular, BP 120-80 millimeters of mercury with a normal JVP. Investigation showed a normal hemoglobin with a total count of 9,200, a normal ESR, RFT normal. We took an ECG which was showing a sinus tachycardia, a chest X-ray showing signs of left atrial enlargement. We did a transthoracic echocardiography on her, which was showing the mechanical valve in the mitral position with an increased gradient across the mitral valve and a mild mitral regurgitation. So you can see that the gradient across the mitral valve was increased. We performed a transesophageal echocardiography, which was showing that one leaflet of the mitral valve was moving very freely, while the other leaflet was not moving, with an area of shadow behind it, and no evident thrombus was seen, with a mild mitral regurgitation seen, and of course an increased gradient across the mitral valve. We did a ciliary fluoroscopy, which was showing that one leaflet of the valve was moving freely, while the other leaflet was found to be immobile. So we were thinking over it. What could it be? Maybe a chronic thrombus or a sinus. And what is the next option for treatment available for her? Either we can lyse the patient or we can do a redo MVR. But we proceeded with a thrombolysis. The next day we lysed the patient with streptokinase 2.5 million units over 30 minutes, followed by 1 million units per hour for 24 hours. And the next day we did a transthoracic echocardiography on her, which was showing the mechanical valve in the mitral position, and the valve leaflets were moving, and the gradients across the valve was measured, which was showing that the gradients across the valve was reduced. It was around 8/5, and a trivial MR across the valve leaflet. We did a ciliary fluoroscopy, which was showing that both leaflets of the valve was moving very freely. And 1 month after, she came for the review. It was showing the transthoracic echocardiography was showing the mitral valve, the mechanical valve in the mitral position with a normal LV systolic function. The valve leaflets were moving, and the gradient across the valve was also reduced. It was around 10/7. So I'm concluding my case with this. Thank you.
Very nice presentation. Hello.
Yes, sir. Thank you, sir.
Yeah. After the echo showed stuck valve, any other investigation did you consider?
Yes, sir. Her INR was around 1.2.
Have you considered TE in this case?
Yes, sir. We did a TE. We did a TE, sir.
We have done.
We have done a TE.
That showed thrombus.
Which showed, yes, sir. Which showed one leaflet was not moving around it, and.
Yeah. So, what is the specificity of transthoracic echo for identifying the thrombus with the prosthetic valve? When you compare TE and the TT and TE, it's always better to go for TE.
It is better to go for TEs.
TE is more specific.
Yes.
Why was the INR so low? Was she non-compliant on medication?
She was non-compliant, sir.
Thank you. Vijumon, you want to ask any question?
No, sir. We had in-depth discussion on the same topic today itself. So, thank you.
Thank you.
We'll move on to third presenter.
Thank you.
Third presenter. Can you have the third presenter?
Respected chairs, I am Dr. Radish Kumar. We are from Government Medical College, Trivandrum. Today in IAE Kerala webinar, I am going to present one interesting case of chest pain. My professors are Professor Dr. Shiva, Professor Dr. Radhakrishnan, Professor Dr. Natdeep, and Professor Dr. Sudhir. My case is a 44-year-old female presented with acute onset chest discomfort and breathlessness. It rapidly progresses to feature-sized right heart failure over a period of 3 days. For these complaints, she initially contacted a local hospital. From there, they evaluated the initial evaluation for acute coronary syndrome. They initially suspected acute coronary syndrome. They took ECG. They take the biochemical markers. All are negative. So they referred her in view of worsening of symptoms, bipedal edema, breathlessness, and all. She was being referred to our hospital. From our hospital, we find nothing in, we again take the ECG, biochemical markers, and X-ray, which does not show any features of acute coronary syndrome, pneumothorax, aortic dissection, or acute events for chest pain. So we want to work up further. So we take echo for the parasternal, the echo parasternal long axis view, which shows LA mildly dilated, RV mildly dilated, LV good, with the aortic valve seems good. Then LA is 4.3 centimeter. Then we in parasternal long axis view, color flow shows some turbulent flow across aorta to RV. From this view, we suspected rupture of sinus of valsalva from aorta to RV. So we took further views which confirmed our diagnosis. So for chest pain with acute breathlessness and right heart failure, RSOB to RV or RA may also be a differential diagnosis. This view, parasternal short axis view at aortic level, we can see a definite turbulence from aorta, probably from non-coronary sinus to right ventricle, which is a turbulent flow we can see. So we confirm the diagnosis. In this view, we can see a defect from aortic sinus to RV, and color Doppler show a definite gradient across that. In this view, we can see a color flow across that defect. So we confirmed the diagnosis and treated her with the decongested diuretics and all. She became symptomatically better. And in all view, there is a gradient. She became symptomatically better and her breathlessness come down. And so we decided to further plan for device closure of that RSOV or surgical closure. Her CT scan is waiting, and our plan is to close the lesion by device or surgical closure. So RSOV to RV or RA is also a consideration in cases of acute chest pain with breathlessness and right heart failure. Thank you.
Dr. Adish, very good presentation. Is it windsock-like this appearance, deformity is there, that defect?
Yes, sir. It's a windsock, but for that we have to further clarify with the CT or TE. But patient was not in a good condition to do a TE. We are waiting the CT scan. Most common presentation is windsock-like deformity, and most commonly from right sinus to RV or RA. Our patient, I think it's from right sinus to RV.
Yes. So what is the importance when you are going for device closure? If it is a windsock like, what is the
Yeah, what is the importance of that when you are going for device closure? No, sometimes there will be multiple defects. Instead of like then
Yes, sir.
multiple defects may be there, so that will throw some problem during device closure. Oh, anyway, you have to confirm.
Yes, sir. We have to confirm before this closure, and we have to assess the size and length of the lesion for which device we have to use, or whether surgery is needed or not.
What is the size of defect? Size of the defect?
By transthoracic echo, we got 5 mm, sir, but we have to further evaluate whether it is 5 mm or what is the length of the lesion. Echo can be used, but the patient was not in a good condition at that time. That's why we are planning to take a 3D echo as well as a cardiac CT to assess the lesion length as well as the size at the aortic site and whether any other channels are there or not.
Okay. You are still waiting for the reports.
Yes, sir. Yes.
Fine. Okay, then, Rajesh sir, shall we move to the next case?
Go to the next.
Good evening, respected teachers and colleagues. I'm presenting an interesting case of a right atrial mass. Our patient was a 31-year-old lady who presented to our hospital. She was apparently well 3 years ago when she developed rapidly progressive dyspnea on exertion. And to begin with, it was an NYHA functional class 2, which progressed to functional class 3 over 2 weeks. It was associated with paroxysmal palpitations and right-sided chest pain. She was evaluated and treated at an outside hospital, and she improved to functional class 2, and she was on medical management for a year. But then she discontinued treatment, after which she progressed to dyspnea exertion functional class 3 and was admitted again and started on medications again. She was in dyspnea exertion functional class 2 until 1 week back, when she progressed to functional class 3 to class 4, and it was associated with right-sided chest pain, palpitations, orthopnea, abdominal distension, and bilateral pedal edema. There was no history of fever or cough or hemoptysis. She had history of drug default and also 3 spontaneous abortions. On examination, she was afebrile and she had bilateral pitting pedal edema. The pulse rate was 90 per minute, regular, normal volume, normal character, normal vessel wall, no radioradial or radiofemoral delay, and all peripheral pulses were well felt. The blood pressure was 130 by 80 millimeters of mercury, and respiratory rate was 24 per minute. The saturation was 95% in room air. JVP was elevated 8 centimeters from sternal angle, with prominent V waves and prominent Y descent. Apex beat was felt in the left fifth intercostal space, 2 centimeters lateral to the left mid-clavicular line, which was forceful, and there was also a grade 2 by 3 parson of leaf. On auscultation, S1 was normal. However, S2, there was a loud P2 with a narrow A to P2 split. A pansystolic murmur of grade 3 by 6 was heard at lower left sternal border, which was high-pitched, blowing in character, and was increasing with respiration. There was also an early diastolic decrease in the murmur, grade 2 by 4, at left second intercostal space. Some remarkable findings in her investigations were she was positive for lupus anticoagulant, as well as anti-cardiolipin antibodies and ANA. On ECG, there was sinus rhythm with features of right atrial abnormality. Chest X-ray was suggestive of cardiomegaly, right atrial enlargement, and a dilated main pulmonary artery. So she was taken off for an echocardiography. And in the parsinal long axis view, you can see that the left atrium, left ventricle, the aorta, they are fairly normal, as well as the mitral valves and the aortic valves. But there is a hugely dilated right ventricle, as well as a mild to moderate pericardial effusion. This is a short axis view of the left ventricle at the level of papillary muscles. And the dimensions of the left ventricle are within normal limits. The ejection fraction was found to be 80%. This is apical four-chamber view showing a hugely dilated RA and RV. And we can see a large lobulated mobile mass seen arising from the lateral wall of the right atrium, and it is moving to and fro with each cardiac cycle into the tricuspid orifice. Also, there was moderate to severe tricuspid regurgitation. The TRV max was 229 centimeters per second, and the max PG was only 21 millimeters of mercury, probably because of that regurgitant jet which is hitting on the right atrial mass. The size of the mass was 6.1 into 2.1 centimeters. And the dimensions of the RV were 7.7 centimeters, and the RA was around 6 centimeters. TAPC was fairly normal, that is 1.8. The IVC was dilated at 2.1 centimeters with less than 50% collapsibility. This is a subcostal view showing the mass in the right atrium, which is mobile and moving to and fro with each cardiac cycle. So at this point of time, considering the background history, the investigations, and the echo findings, we made a probable diagnosis of a right atrial thrombus, and she was sent for a CT scan. So in the CT thorax, it revealed that the calcified mass in the right atrium, measuring 5.8 into 3.6 centimeters, along with a moderate pericardial effusion, as well as dilated pulmonary arteries. However, there was no evidence of pulmonary embolism. Following this, she was sent for surgery, and she underwent surgery along with de-Baga repair of the tricuspid valve. A 6 into 4 centimeter variegated mass of firm to hard consistency arising from the lateral wall of the right atrium was resected, and this mass was sent for a histopathological examination for confirmation. And in a HPE, it was found that thrombus with eosinophils, fibrin, inflammatory cells, and areas of hemorrhage, along with extensive areas of calcification. Hence, our diagnosis was confirmed as a case of calcified right atrial thrombus. Now, a few words. The thrombus in the right atrium is a rare event, and it can occur following ESG repair or patch closure, central venous catheterization, cardiac pacemaker installation, hypercoagulable states, atrial fibrillation, and individuals with significant right heart failure. Its incidence is around 0.75%. The likelihood of thrombosis in the right atrium is substantially lower than in the left atrium. Even rarer is the occurrence of a calcified thrombus in the right atrium, with hardly few cases reported worldwide. The clinical symptoms and or signs may only manifest in response to cardiac hemodynamic change, embolism, or invasion of the pericardium, making their early clinical diagnosis a challenge. So, given the rarity of calcified RA thrombus and the lack of conclusive information, therapy is still debatable since there is no clear consensus on the best course of action. Thank you.
Procedure removed that mass from the right atrium.
So we have sent the patient for surgical removal.
Yeah. Did that mass warrant surgery being the right atrium? The patient did not have pulmonary hypertension. Could a percutaneous procedure like catching the mass and removing it through the right atrium, would that have been possible rather than a more drastic surgery is a question. I just want my co-chairs also to give opinion. Dr. Ramkrishnan, Dr. Biju Mohan.
So she was positive for lupus anticoagulant, you are telling?
Yes, sir.
Did you tell that? Yes?
Yes, sir. Yes, sir. Lupus anticoagulant.
Dr. Biju Mohan, what is your opinion about surgery?
Okay, surgery. He has already undergone surgery and the mass was resected, no, sir? No,
Right,
was
right.
it advisable? Okay, that's what you are asking. Hello? 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 Hello?
Right.
Yeah.
Okay.
Hello?
Yes, sir, we can hear you.
Yeah. I think surgery may be the best option because it looks the big mass, and anyway, you have to get the pathological diagnosis also. I think so.
I think. Sure.
Okay, then I have one question.
Yes, sir.
actually, any other differential diagnosis after doing the echo, we are seeing this much mass in right atrium. What are the differential diagnoses we can consider?
So other differential diagnosis can be it can be tumors. It can be a primary or a primary tumor or a secondary tumor. Or it can be other vegetations, very large vegetations.
Vegetation. Can you consider vegetation in this case? What kind of vegetation?
So if it is a large vegetation with abscess formation, then we can.
Because since patient is having a SLE, so what kind of vegetation? So non-bacterial endocarditis is possible, no?
Yes, sir.
SLE.
Limb sacs vegetation.
Limb sacs endocarditis, yes, sir. Yes, sir.
So yeah, because it can appear anywhere. It can even not be involved, not attached.
Yes, sir. Yes, sir.
Okay.
Okay, sir.
And in the echo wise, how do you diagnose a thrombus? Echo. What are the usual appearances of thrombus?
Thrombus is usually a hypodense structure, sir. And yes, hypoechoic, and it can be either pedunculated or sessile. It can be attached to the wall of the RA, or it can be fully mobile also.
Yeah, usually different types of echogenicity. Some hypoechoic also like that usually. Okay.
Yes, sir.
Sir, Rajesh sir.
Yeah, it could be a right atrial mass. Some patients with tuberculosis also can present this right atrial mass. Anyway, this is a very good case. Proven surgically also. Good outcome. Thank you very much.
Thank you, sir.
We'll move on to the next case. Dr. Bijumohan, you want to have any comment?
No, sir. Is she on any oral anticoagulation or something right now? And what happened to her? Like follow-up? I was just asking.
So actually, we lost the patient after surgery.
No, following something. What was the for?
No, sir. Yeah, so we lost the patient after surgery. After surgery, so we lost the patient actually. 5 days after the surgery, she was on mechanical ventilator support, and she was continuing to have severe pulmonary artery hypertension, and she couldn't be weaned off from the ventilator, and she subsequently succumbed.
That's the point, and it could this mask could have been removed non-surgical, because this patient did not have a good surgical outcome, although you have the issue diagnosis. Now we get some devices which can remove this kind of masses from the right atrium, percutaneously. So that is my point from the beginning itself. Why surgery?
Yes, sir.
Anyway, thank you very much. We'll move on to the next case. Shortage of time. Thank you very much.
Good morning, everyone. Yes, it is malignant, as said by William Henry. Let's start with my case. My case is a 69-year-old diabetic female. She had a history of fever, continuous type, associated with chills and rigors, treated for 5 days in a private hospital as probable dengue fever, and discharged for the same. After discharge, she again developed fever, which was high degree, continuous type, associated with chills and rigors, and now with a new onset apical murmur, for which she was referred to medical college Trivandrum. On admission, she was febrile with temperature of 102 degree Fahrenheit. Pulse was 110 minutes. BP was 160 by 100. Serious examination, JVP was not elevated, S1 is to be normal. There was a grade 3/6 pan-systolic murmur which was heard in apex radiating to the back, high-pitched murmur. There were no peripheral signs of endocarditis. Lab values, hemoglobin of 9.2 gram, total count of 22,000. ESR was 130, which was elevated. CRP was 48, which was elevated, with normal RFT values, baseline RFT values. So we took her for a thoracic echocardiogram. First image, this is an image, not a video. It showed a large 1.8 into 1.3 centimeter vegetation seen attached to the posterior mitral valve, which was extending into the LV cavity. When a repeat echo done after 30 minutes, that mass got embolized and a small vegetation seen at small pressure PV mobile mass seen attached to the posterior mitral valve was seen. So we made a diagnosis of mitral valve infective endocarditis. Blood cultures were sent, which turned out to be negative. This can be due to antibiotics she received before coming to hospital and in hospital antibiotics which were given, IV antibiotics were given. So a culture negative infective endocarditis diagnosis was made. Antibiotics were started, injection vancomycin 1 gram IV BID. On day 10, patient's RFT worsened from create 0.8 to 1.8, and dose of vancomycin was reduced to 500 mg OD. Patient's daily temperature monitoring showed daily fever spikes for initial 7 days. This led us to doing a repeat transthoracic echocardiogram. This is a repeat echocardiogram, transthoracic echocardiogram done on day 7 in view of persistent fevers, which show a moderate pericardial effusion and moderate pericardial effusion with increase in the MR severity. A patient with infective endocarditis developing a moderate pericardial effusion and increasing severity of mitral regurgitation should prompt us in search of any complications that are associated with infective endocarditis, which include but not limited to paravalvular abscess formation. So a detailed echocardiogram done on the same day showed an echolucent mass with irregular margins located near the annulus of the mitral valve, suggesting the paravalvular abscess. This kind of echolucent mass seen in the paravalvular area, this area, we can have a differential diagnosis of coronary sinus, but coronary sinus will be more have a regular margins and it will more irregular margins. But in this situation, a diagnosis of paravalvular abscess was made. This paravalvular abscess resulted in severe mitral regurgitation as seen in the previous video. This was confirmed by the repeat transthoracic echocardiogram, which was done after 3 days. Follow-up echo confirmed paravalvular abscess with cavity formation. This we can see the paravalvular area. So, infective endocarditis, a variety of complications may occur in the setting of active endocarditis that affect the outcome and management. Fever spikes usually subside on day 5 or 7 after initiating IV antibiotics in patients with active endocarditis. This is a dictum. Fever not subsiding should always prompt us to change the antibiotic or look for any complication that is associated with infective endocarditis. But development of pericardial effusion with fever spikes should always prompt us for the evaluation of complications, which include paravalvular abscess formation. My conclusion from this case is, this case demonstrates the importance of serial echocardiographic evaluation in infective endocarditis patients. Demonstration of paravalvular abscess in an infective endocarditis patient suggests that there is either inadequate antibiotic therapy or virulent nature of the organism. Inadequate antibiotic therapy in our patients, as she should develop vancomycin associated EK or deranged RFTs, we reduced the vancomycin dose. Also, virulent nature, we were unable to isolate the organism as patient previously received antibiotics. So it was a very difficult case in our case. Also, paravalvular abscess formation commands for the early need of intervention, surgical intervention, which is one of the most important causes for surgical intervention in infective endocarditis. So always search for a complication in a patient, complication like paravalvular abscess in a patient who is receiving antibiotics and having fever spikes or developing pericardial effusion after day 5 to 7 of their antibiotic infusion. Thank you.
But Darshan, why this caption as malignant? Darshan, hello?
Hello.
Yes, it is malignant by that caption. And I was thinking there is some underlying malignancy on which the abscess developed and all.
No, sir. Actually, sir, first case series published by William Harvey of infective endocarditis, he presented it as malignant carditis actually. So now our patient also had malignant force in the hospital stay. So
Yes. Yes, no connection with malignancy.
no connection.
Okay.
Actually, it is infected
So,
endocarditis only, which is progressing.
Can there be some underlying malignancy presenting like this?
So, sir,
Yes, Ramarshal.
I don't think so.
Okay,
She had fever.
when will you consider surgery in case of infected endocarditis?
Sir, infective endocarditis patient usually vegetation size more than 10 mm, or any patient having significant complications associated with infective endocarditis like development of paravalvular abscess, severe mitral regurgitation, patient not responding to regular antibiotic course A5. Then we are then we are supposed to take for surgical intervention, early surgical intervention.
And other than bacterial, fungal endocarditis and all.
A very large vegetation also.
Very large vegetation, more than 10 mm.
This was very large vegetation.
This was very large vegetation which started.
What the patient had an embolism also. Did the patient have a stroke?
No, sir. No, sir. No signs of embolization was made out in this patient. Initially, she was stable. Later, she developed AF and VT. Later, she succumbed on day 20th, sir. She had a malignant.
She had surgery?
No, sir. No, sir. No, sir. She was not. Patient bystanders were not keen on surgery, and the patient was ill actually. He was,
Okay, I think we will move on to next case.
Thanks,
Rajesh sir.
Good evening to all. Myself, Dr. Prem Shankar. I am here to discuss a case of grown-up congenital heart disease. Coming to my case, it's a case of 17-year-old female with history of cyanosis, which first appeared at 3 months of age, and there was history of cyanotic spells also. After which she underwent a corrective surgery at 2 years of age. Post-surgery, she was in function class 1, but from last 2 years, she is having dyspnea on exertion, function class 2 symptoms, for which she has presented to us. On examination, her pulse rate was 80 per minute, regular, normal in volume and character, with no radioradial or radiofemoral delay. All peripheral pulses were equally palpable and bilaterally symmetrical. Blood pressure was 110/70 millimeters of mercury, and similarly all 4 limbs. Oxygen saturation was 100% in all 4 limbs, and it remained unchanged on exertion. On general examination, the findings were unremarkable. Now coming to cardiovascular system examination, her jugular venous pressure was elevated 12 centimeters above sternal angle with a prominent A wave and prominent X descent, while V wave and Y descent were normal. The precordium showed a midline sternotomy scar. Apex beat was not palpable. Pulsations were present in second left intercostal space. On percussion, this left second intercostal space was dull, and this dullness extended up to 2 centimeters from the left sternal border, while upon auscultation, S1 was found to be normal, S2 was single and loud. There was no S3. RBS4 was present. Pulmonary area had a grade 3/6 high-pitched, long, ejection systolic, crescendo-decrescendo murmur, which was late peaking and was best heard with diaphragm. The murmur increased on inspiration. Pulmonary area also had a grade 2/4 high-pitched, early diastolic, long, decrescendo murmur, which was best heard with diaphragm and also increased on inspiration. All her biochemical parameters were found to be within normal limits. Coming to ECG, ECG showed sinus rhythm with a rate of about 75 per minute with a normal P wave and PR interval of about 180 millisecond with a wide QRS complex of duration about 170 millisecond with right bundle branch block morphology and right axis deviation. The precordial leads were showing right bundle branch block pattern with right ventricular hypertrophy, and RVA strain pattern also was seen. Coming to chest X-ray, it was a PA view X-ray with slight overexposure and slight rotation to the left side, and it showed normal bony casions of the shadow, and the cardiothoracic ratio was about 0.55. That is, slight cardiomegaly was there. Coming to right heart border, the right atrial was enlarged, and coming to left heart border, and the aortic knuckle was normal, followed by a convex main pulmonary artery segment indicating main pulmonary artery enlargement, and the apex was more of RV type. And coming to lung fields, and the lung fields showed, especially on the right side, there were multiple indon views, and the lung field showed pulmonary oligemia, which was more pronounced on the left side. Coming to our echocardiography, and this is an epigastric view. It shows right side has an IVC and aorta on the left side, that situs soletus is present. Now coming to a parasternal long axis view, and this showed a normal left atrium opening via normal mitral valve into left ventricle, which is a bit smaller compared to the enlarged right ventricular outflow tract, and the normal aortic valve and drains into normal proximal aorta. Now Doppler was put across mitral and aortic valve, and it showed no flow turbulence. And M mode across the aortic valve showed aortic root dimension of 27 millimeters and LA dimension of 31 millimeters. Now, a short axis view across partial short axis view at the level of mitral valve showed a small LV, a large right ventricle, which is compressing the septum, so that there is a D-shaped septum during systole, indicating a RV pressure overload situation. And in M mode across the left ventricle, we can see the reticular ejection fraction was 77.5%, which is a good LV systolic function. And there was some desynchrony of septum and posterior valve due to the right bundle branch block, which we saw on ECG also. Now coming to short axis view at the level of aortic valve, we can see entirely flat normal aortic valve, and right atrium opening into right ventricle, which is enlarged, and right ventricle draining into the pulmonary artery. Now, Doppler was put across the pulmonary valve, and we can see that there is turbulence of flow in the main pulmonary artery segment, and there is pulmonary regurgitation is present as well. Now, pulmonary artery focused short axis view at the level of aortic valve showed that there is narrowing in the main pulmonary artery segment. Now, on putting Doppler across that segment, we can see flow turbulence, and the diameter measurement at that segment was only 9 millimeters. Also, and on putting color M mode across the pulmonary valve, we can see red jets of pulmonary regurgitation during diastole. Similarly, in continuous wave across pulmonary valve, we can see the downwards normal flow from RV to pulmonary artery, as well as the upwards regurgitant, pulmonary regurgitant flow. And the pulmonary regurgitant velocity is about 1.8 meter per second, while in the normal pulmonary valve, Vmax is 1.3 meter per second, and gradient is about 7 millimeters of mercury. The pulmonary valve acceleration time is 88 milliseconds, which is indicating mild pulmonary artery hypertension. Now coming to apical four-chamber view, and this showed normal LA, LV, and RA and RV, and there was no mitral regurgitation, while there was mild tricuspid regurgitation, and the tricuspid regurgitation velocity was about 220 centimeters per second, while there is no turbulence across aortic valve, and TAPS is reduced, showing some degree of RV dysfunction. Thank you. So the final diagnosis of this patient was post repair of cyanotic congenital heart disease, most probably tetralogy of Fallot, with recurrence of pulmonary stenosis and RV systolic dysfunction. Thank you.
sorry. No, very good presentation. You have elaborated in detail all the echo, all the views and all. So what are the positive findings in echo?
So the positive findings where there was some degree of pulmonary stenosis in the main pulmonary artery segment, and there was moderate pulmonary regurgitation was there. And pervasive swelling.
What is the severity of pulmonary regurgitation?
Sir, it was moderate pulmonary regurgitation.
How do you assess that severity of pulmonary regurgitation?
Sir, by the how much of the RVOT is being occupied by the pulmonary regurgitation jet by the kinesis?
So pulmonary stenosis is also very mild.
Yes, sir. Yes, sir. Mild pulmonary stenosis is there. I could not demonstrate a significant gradient.
So acceptable, no? Post-surgery, this mild PR, even mild to moderate PR or even mild residual stenosis is acceptable.
Yes, sir. Actually, sir, it's common. She underwent transannular patch repair, and so after that, pulmonary regurgitation is common, and in a long-term follow-up, these patients develop RV systolic dysfunction as we are seeing in this patient. So that is causing her functional limitation.
Is there any
One
evidence of PST patch closure? PST closure?
No, sir, no patch I could demonstrate, sir. I couldn't see any patch, definite patch there.
So clinically also you have a dilated pulmonary artery.
Yes, sir. Yes, sir.
Did cardiac MRI was done?
No, sir. Cardiac MRI was not done, sir.
Okay. So which are the indices which determine the necessity for addressing pulmonary valve?
Sir, it is given by Thal-Giva criteria. Sir, in asymptomatic patients, 2 or more of Thal-Giva criteria positive indicate pulmonary valve replacement. So the criteria include RV and YLV time volume more than 2.
Rajesh sir.
Sir, Rajesh sir has left actually.
Okay.
Okay, I think we will wind up the session, no?
Session is over almost.
Okay.
I thank Shivaprasad sir and team for giving us this opportunity, sir. Shivaprasad sir.
Yes, sir. Yes, thank you, speakers and all the chairpersons. Rajesh sir has already left. Ramakrishna sir and Bijumon sir for readily agreeing for chairing this session. Being a weekend and a busy schedule, you have come for joined us for this talk. We are really indebted to you.
Thank you. Thank you so much.
Okay, thank you, sir. Thank you.
So we are almost on time, and we'll have the concluding remarks by the scientific committee chair as well as the president of IAE Kerala. Suresh sir has also joined. So I think we have the important declaration of awards by the scientific committee chair. The judges have passed the results to sir, and maybe sir can declare.
Before I go into the results, let me thank all the speakers who made excellent presentations on a lot of topics with much enlightening knowledge which was shared between us. And all the presentations were very good and of very high standard. In fact, the award session was actually quite inch to inch. And I got the results with me now. And also I thank especially Raj Janardhan for his taking his time in early morning hours in Arizona to give us a very enlightening lecture on mitra clip assessment, pre-procedural assessment. I hope all of you have enjoyed the scientific feast, and my guru Suresh sir is already here. So he will conclude. Before that, I will declare the much weighted results. The third prize for the presentation goes to Achyutananda Govind Sundara Vadivelu from Government Medical College, Calicut. Second prize goes to Sanithan Rangaswamy from Velamadi Hospital, Madurai. And the first prize goes to Suhas Allur from Government Medical College, Calicut. Over to Suresh, sir. And these persons will, first prize fetches 10,000, second prize 5,000, and third prize 3,000, and that check will be mailed to you. Over to Suresh, sir.
Thank you, Professor Shivaprasad, for handing over the baton to me at the concluding leg of the session. As you said, it was truly an excellent day of academic sessions. I enjoyed, it was truly a learning experience for me also. All the case presentations were excellent. Actually, I wonder how you managed to shortlist some for the award session and some for the non-award session, because many of the presentations were of very high standard, even in the non-award sessions. It's a very, very difficult task. Yeah, I think you have done a very, very good job. It's excellent. I would like to congratulate you on behalf of the entire team. And of course, our dynamic, our secretary of the chapter, Ravi, for doing all the groundwork and making the necessary arrangements with the audio, visual, and other teams. Bino, was he here? I didn't notice.
Yes, sir, he had joined us for one session. He was here.
Joe had
unfortunately, our secretary could not make it because
I know that Joe was traveling.
Yeah.
Anyway, overall, it was an excellent day. I think I should thank all the delegates, all the participants, all the chairpersons, all the speakers for those wonderful presentations. Thank you very much, and over to Praveen for winding up.
Yeah, thank you all. We should thank all the chairpersons, the speakers who had already agreed, in spite of being it a weekend and everybody was busy, but they did join us. Thank you all for joining us, and then we'll thank AM Audiovisuals for arranging this technical things. They are also supportive. Then we have our office secretary, Mr. Anish, who has been always supportive in this endeavors. So thank you all, and good night.
Good night.